Morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have a couple of bills that we're going to be hearing this morning. But before we do that, I'd like to ask everyone to please join me in the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. The first bill this morning is Senate Bill 239, and I'm pleased to recognize the prime sponsor, Senator Waters. Good morning, Senator.
Good morning, Mr. Chairman, members of the committee. Nice to see you all. Senator David Waters, District 4, to introduce Senate Bill 239. And as you see from the summary of the bill here, that it does a variety of things related to harm reduction services and treatments for substance misuse. And I'll go through the bill in just a moment, but I bring the bill before you really as the result of a lot of work by members of this committee and the House and the Senate and many others. And I want to note particularly the Harm Reduction Study Committee that we had last summer and last fall. Representative Healy, former Representative Woods, and Representative Edwards were all parts of that. And I had the copies of that study sent to you because the bill really arises from all the issues that we looked at in that study. But of course, the bill and our whole response to substance misuse is a result of partnership over many years trying to address these issues. I do want to point out particularly Governor Sununu, with the wisdom of establishing a Doorways program and getting a grant there, which is a huge step forward for the state. The Commission on Alcohol and Other Drugs, Patrick Tufts, I'm on that commission, as several legislators are. New Hampshire Providers Association, New Hampshire Harm Reduction Coalition, and recovery organizations. Thanks to the Manchester Chief of Police, Mayor Craig, and the chiefs of police in general who have worked on these issues and really out there in our communities on the front lines, the EMTs and others. And I think in the legislature, I think back former Representative Hannon, who pioneered needle exchange programs along with Senator Gray and Senator Bradley and members of this committee in the House. And so I just want to acknowledge that there's been so much good effort in the state, and that's the New Hampshire way to try to see what we can do about the substance misuse disorder, the opioid crisis. So the bill does a variety of things, and I want to start with what it does in the first few pages related to the Governor's Commission, alcohol and other drugs. What you see here essentially embeds the language of harm reduction throughout the statute for the Governor's Commission, because the strategic plan which the Commission has developed over the last couple of years creates a new area, one of its task force groups in the area of harm reduction. So working with Patrick Tufts and other members of the Commission, these kind of revisions acknowledge the newly developed aspects of the mission of the Governor's Commission. You'll see also on page 1, line 19, that it seemed to make a whole lot of sense to add the president of the Hampshire Association of Chiefs of Police, or designee, to the commission. They're very glad to be included here because they are doing so much work, and their leadership on a lot of the issues related to substance misuse, and they'll be a good new voice on the committee. So this is what gets us through the first couple of pages. You'll just see the language is dropped in there. And then I would like us to, if we could please, turn to page 3, and another important new connections that's made here relating to the Opioid Abatement Advisory Commission. This was set up rather quickly when we received the settlement funding on the opioid suit, and that at the time it did not include a formal process of liaison with the chair of the Governor's Commission on Alcohol and Other Drugs. So this is the language that the folks on that commission thought would make sense. So you'll see here the new subparagraph, upon consultation with the Governor's Commission on Alcohol and Other Drugs, provide funding for syringe service programs, which is something that is authorized under the opioid abatement settlement. So the consultation will be there, and this is the same language as was put in Senate Bill 32, which was sponsored, recommended by the Commission on Abatement. So that this kind of ties those up together well. Then starting on the bottom of page 3, section 10, it seemed to make sense to put the Doorways program in statute. As I said, commend Governor Sununu on his leadership, establishing 11 Doorways programs around the state. They have evolved. They are receiving about $28 million in federal funding at this point. It really, I think, makes sense because of the success of that program, that it become a part of statute and a permanent feature of the ways in which we're trying to address substance misuse. Please do note that we amended the bill in the Senate to make sure that it is specifying existing federal funds. You'll see that the fiscal note suggests that if we lost the federal funds, we'd have to find some state support. But I think the record of what our delegation has been able to secure for us and the commitment of federal grant funding, I think that won't happen. But it's important to note that there's not a fiscal note related to this because we are not requiring state expenditures on that program at this time. Then on page 4, we get more into the heart of harm reduction activities that are underway. And first off, it takes another look at the syringe service programs, the needle exchange programs. And we heard an awful lot from the chiefs of police, and particularly from Manchester and other cities on the seacoast and elsewhere around the state, that we need to coordinate better of how the syringe services programs are being run. I know there was some legislation in the House that tried to get at this issue as well. And I'm very pleased that this bill now is good with the chiefs of police in this version, and that's an important step forward in that partnership. So what it does is it says that syringe service programs should coordinate and collaborate with other local agencies, but including criminal justice. And that's an important way to avoid some of the problems that have occurred in the operation of those programs without that coordination. And you'll see a little bit further down, lines 12, 13, the same. Consult and inform municipal law enforcement agencies concerning syringe service program and harm reduction activities. It took a lot of work to get to that language with the chiefs of police, and with Manchester and other municipalities. But I'm pretty comfortable that we reached a good place on how to make sure that we have everybody on board with that. Then continuing to section 13, I remember when we set up the syringe service program, I worked on that legislation with Senator Gray when we finally got that done. And part of that there was to prohibit the use of any state funds, and that was necessary at that time. And there were some federal guidelines about that as well. But it seems that one thing you'll hear if you talk with syringe service providers programs around the state is that they're really nervous about sustaining their funding. And the syringe service programs, I mean, my goodness, do we need them? Disease prevention, somebody gets HIV or Hep C, we're looking at $350,000, $500,000, or if you have a heart valve replacement, the wound issues that we're now seeing with xylazine and other things that are, wounds are extraordinarily expensive to treat. And so a 10-cent needle and some clean swabs can prevent extraordinary expenditures otherwise. So that's why it doesn't mandate it, it just opens the door to it. And you'll see in the fiscal note that the Department of HHS says that under existing funding, we can handle this. But I think it's important to assure the syringe service program community that as they provide their necessary services, that we're not going to let them fall apart if the grant, if they're grant funding. And also they're getting a lot of free contribution from hospitals now that are letting them put the the syringes they exchange into the disposal. Disposal is expensive, and the hospital is saying you can put them into our disposal stream without charge, and that's a huge help. So we're kind of working so hard to get this successful, and I think this is important there. And then on section 14, we get into the paraphernalia issue, and I know that this has been the subject, and I do want to thank Representative Muse for his leadership, and other members of the House for their hard work in this area as well. All the harm reduction areas, Representative Muse and the bills that they have come into the House trying to get at this issue of these things. And so the way that this bill does it is to focus on the people who are providing the services authorized under RSA 318B43. You'll see in lines 24, 25 on page 4, that those folks who are authorized to run these programs by HHS, that notwithstanding the language on paraphernalia, that they can have in possession these items. So I think it's really important to say to the folks who are operating the programs that you're not going to be arrested because you have certain supplies that you are going to be distributing at your harm reduction program. And so that's why that's key there in lines 24 to 26. Then a bunch of definitions. So what do we mean? And you'll see drug checking equipment. And I'll continue on to page 5, supplies, the syringes, preparation containers, and so forth. Eligible activities mean that they can get these materials, do the training as needed on the drug checking, technical assistance about them, and then providing them. So I just want to pause on that because I think this is important, because I know that you've had bills about this. This is one that seems that the syringe service providers, law enforcement are comfortable with the way this one is done. The last part of this bill addresses medically assisted treatment. And as you may know in this area, that it's been somewhat difficult to ensure that we have medical providers who have the necessary training so that they can do the prescribing for medically assisted treatment. It was that you had to get something called an X waiver, which was an additional waiver on your prescribing license that lets you do this kind of prescribing. And depending on the extent of training, you could treat up to 25 patients, or you could do more. And it was cumbersome and difficult in some ways, and really wasn't serving the population that was needed. Now, between the time I first drafted this bill, when I was working on the X waiver issue, then our federal delegation got language inserted into federal legislation, which got rid of the X waiver. Hooray. So what the bill said, okay, let's then go at the issue of making sure that people, when they get relicensed, get some training. And so it's a very light touch. It could be online training, but when you go in for your relicensing, and it lists here the what professions we're covering with that you get the training. And I decided to go with this way because I talked to providers, and doctors in the field, and they say, if you're coming through a medical school now and relatively recent graduate, you got this kind of training about harm reduction and about prescribing. But that depends on the medical school, and a few years ago it just wasn't happening at all. So this said, and I think it's also a light touch in that it doesn't say the first time you get a license. It's when you go in for your first renewal, that's the point. You can demonstrate with all the other training you have to do to maintain your license, that you can demonstrate that you've done some education in this area. So, Mr. Chairman, members of the committee, I appreciate your indulgence for my long introduction of the bill, but it's a lot of little pieces in here. And I wanted to just walk through it, and I'm happy to take any questions you may have.
Thank you, Senator. Representative Weber.
Thank you, Mr. Chairman, and thank you for the walkthrough. I just wondered when we talk about the medical licensing and relicensing, you've got physicians and surgeons and you have physicians assistants. Is there a reason why we don't include APRNs? Do they not do
Thank
this
you
work?
for the
I know they
question.
prescribe, so.
Yeah, it may have been an oversight on my part, but I thought that it was inclusive of the folks who were doing medically assisted treatment and were allowed to do so. But if I've missed
I
somebody,
don't know.
I'll check. I will check as well. If I've missed somebody, that is an error. But I think I identified the ones who actually now are authorized to do it. But I maybe we'll hear from someone behind me. Yeah. Thank you for the question. Yeah.
Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I have two separate questions. Can I do that?
Sure.
So the first one's a response to that one.
Yeah.
I assume you're already aware that it's in medical rules that we're required every CME cycle to do 3 hours of training in opioid prescribing or harm reduction. That's already exists. Were you aware of that?
Don't know if I saw that. So if this needs to be revised just to specify towards that rulemaking, because it may not be in statute. I mean, I wanted to put it in statute. That's what I wanted to do. I mean, rulemaking, but in statute is what I wanted to do.
So that brings me to my second question. This is my night job. My day job is that I advocate for the rights of people in pain. I've been doing this for 35 years. I wrote the state opioid prescribing rules. My big thing is barriers to healthcare, and harm reduction is a big issue for us. Our concern is that every time somebody comes up with a bill like this, that my people get neglected, and in the end, they get harmed. I just got back from Dallas, speaking with a group of about 100 patients who are very angry. What I think would help legislation like this is that we have to realize that there are people that actually benefit from opioids, and that about 16 million at least benefit from long-term opioid therapy, including people at end of life. And they always get left out of these committees, and I would suggest that, I'm curious what your thoughts are, that we put people that are actually affected by pain on these committees so that they can advise them about harm reduction and how the bills are actually can be better designed so they don't harm them.
Well, thanks for your questions. And, I think the intent here is to, I know we have things in rules, but I was on JELCAR for many years, and I know that there was a desire throughout JELCAR's proceedings that if something is in rules, we ought to have legislative authorization for that. And so that is part of why this is specified in legislation. If the committee has some wisdom about how to change that or whether it's necessary, if you have some consultation with folks who are working on this, then fine. On your earlier point, I can't speak for the Governor's Commission on Alcohol and Other Drugs. I think it would be useful to talk with Patrick Tufts if you have some thoughts in that area. I will say, having worked on the strategic plan and being on the commission and being on the task force that's related to this area, that the idea of the task force is that it talks with everybody. And so that, it's a pretty big commission. And a lot of people in various communities are represented there. And there's nothing that prevents the commission from talking with the folks that you're including, even if they're not officially on the commission. But I think that's a conversation to have with the chair, Patrick Tufts.
Just as a quick follow-up.
Sure. Go ahead.
I'm actually the vice chair of the Opioid Abatement Commission. I bring this up at every meeting, so.
Oh, excuse me. I was referring to the Commission on Alcohol and
Yeah,
Other
we
Drugs.
interact with each other.
Yeah. So, I mean, I'm on the Commission on Alcohol and Other Drugs. I mean, the Opioid Abatement Commission is its own thing,
Yep.
and I respect that.
Yeah.
What I was referencing to is the Commission on Alcohol and Other Drugs. And that, I mean, the other commission, if your commission wants to do something in context of this bill,
Great.
but I thought you were referring to the other one.
Yep, thank you.
Thank you. Thank you, Mr. Chairman.
Representative Palmer.
I'm out of practice. Thank you, Mr. Chairman. Thank you for taking my question. First thing is I just wanted to say that was really pleased to hear you talk about the harm reduction. I've been taking care of too many people with long-term wound infections and a recent heart valve replacement in a 29-year-old. And obviously that's a huge cost and huge use of resources. My question is really nitpicky though, which is you're asking that the audit by the New Hampshire Medical Society of those continuing medical education credits be done annually, where our licensing is every 2 years. And I'm just thinking of how small an agency the medical society is, and whether that ought to be every 2 years as we're renewing.
Yeah, thanks for your question. That is existing statute. Yeah, so what this bill does is just the bold there on lines 31 to 33, and so I got to plead my ignorance about the audit issue because it's just existing statute.
If it's already in statute, I'm sure they would have complained about it already.
Thank you.
Thank you. Representative King.
Thank you, Mr. Chairman. Thank you, Senator, for taking questions. Harm reduction, I couldn't find a specific definition of exactly what harm reduction is within this bill, so I apologize if I missed that. But I'm also curious, is the harm reduction only intended for the drug misuser, or is it for society as a whole? My concern is that this legislation is going to, or is patterned after what we're seeing around a lot of the country, where we've been bending over backwards for quote unquote harm reduction for the drug misuser, but society as a whole is just being ravaged by needles being littered in the streets, people defecating in the streets, homelessness, violence. I mean, and my concern is do you see any chance that we're going to turn in to a lot of these other blue cities as a result of something like this? Thank you.
Yeah, thanks for your question, and I really appreciate that, because I think what you're getting at is the kind of interlinking of the issues that people are facing, because certainly substance misuse, mental health disorders, homelessness, go down the line, and you talk to the people, law enforcement or service providers in the streets, and they'll tell you how there are many factors here. In terms of, in terms of this bill, it does kind of necessarily look at harm reduction through the lens of substance misuse disorders. Now, I've talked a bit about, opioids and so on, but the Governor's Commission on Alcohol and Other Drugs is really quite comprehensive in what it looks at. If you look at the Doorways program, people can present there with many, many different kinds of substances that are there. So the harm reduction doesn't necessarily in this context focus on substance misuse. But to your larger point, harm reduction wants to keep people alive. And, some in the recovery community myself for 40 some years now, it's really stuck with me that you can't go into recovery if you're dead. And so that the notion here is that these harm reduction services provide an access point. And if you go out and you go with one of the vans or go to the parking lot of Nashua, wherever these services, and you observe how it's being done, that there's a kind of a check in there, wellness, the naloxone is given, maybe some needles exchanges, maybe some other supplies, but that becomes a relationship. And people who engage in harm reduction programs have a vastly higher percentage of then entering recovery and being more successful in their recovery program, and that starts to help address the larger issues that you're talking about. I will also point to Governor Sununu's leadership. We're trying to address this, but look at all the work that is being done in housing. Look at all the work that's being done on mental health. These are complex problems. I think we can do some good. Thank you for your question.
Representative Leon.
Thank you, Mr. Chairman, and thank you, Senator, for bringing this bill to us. I have two questions around the funding aspects, if I can ask those. My first would be if you know what the level, if it's a percentage or a dollar figure that the federal funding is currently for the Doorways program. And if you don't know, I can't
the-
follow up.
The fiscal note says 28 million.
And is that done at a percentage basis? Do you know? Or is
Pardon?
that is it paying for the entire program right now?
Yes, it's a
Okay.
grant-funded program. Yep.
Perfect. Thank you. And then my second question is on the syringe funding. Would prioritizing that for use of the opioid abatement fund be something that was logical in your mind as opposed to just going straight to general funds?
Well, thanks for the question. See, we got a settlement that puts, I don't have the millions in my head, but we got a substantial settlement, and it may not be the last settlement we get from the industry for the lawsuits that we brought forward. And so the decision was made wisely, let's put that in a fund, a separate fund, and establish the committee that would decide how best to spend those funds. You know, smart move from the governor. You know, I mean, that was the way to do it. And from the legislature too. I mean, you know, good move to do it that way. And so the priorities in terms of how that funding goes out are set by the Opioid Abatement Commission. So that's really, I think, a very appropriate way that it could determine, working with the Governor's Commission on Alcohol and Other Drugs, to figure out if proposals come forward to the Abatement Commission, how much money they're going to put out, and that can be coordinated with the amount of money that is being put out through the Governor's Commission, potentially, from federal grants. So this does not require a certain amount. This is enabling.
Just one follow-up.
Sure.
And then reading between the lines, it seems that this is sort of a partner bill to Senate Bill 32, which is the one about that. So looking at the two of them together would make sense.
Yes, thanks for the Senate Bill 32 deals with several issues related to the Opioid Abatement Commission. And so I wanted to make sure, because I had a little different language, and so I worked with the sponsors of that bill to make sure that in both bills that we've got the same language, and that is the language suggested by the Opioid Abatement Commission to
you.
do it in this bill, to have it like that.
Thank you.
Other questions? Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. For the longest time, it seems to me that, our state strategy for dealing with the terrible problems with substance misuse and overdose deaths have been, the strategy follows the money. So a grant comes, we create a program, the grant goes away, the program closes. And I'm wondering if putting the doorways into statute and saying the money that goes towards harm reduction can come from the general fund, is this move us any closer to having a New Hampshire-based long-term strategy to deal with this problem? I don't know that it's being tremendously successful, but it's certainly we've moved forward with having a long-term strategy based on what the state needs. So is this concretize that?
Thanks for your question. And, when any kind of emerging problem or crisis develops, there are a lot of things that are tried. Some work, some don't. And I think that for the federal government as well, that, maybe the grant funding didn't address certain things. And I think that they've gotten better at just, they understand federal money has to come into these programs, but what's going to work and what doesn't. And I think that's why I argued that the demonstrated success of the doorways. So New Hampshire's tried a lot of things, right? We have a lot of, law enforcement, Granite Hammer. We've done that. We've worked with the feds on certain things. We've tried with the medical society. We've tried providers. We've tried with the recovery organizations, recovery housing. We're trying a lot of things, but I think what's emerging through the strategic plan of the Governor's Commission on Alcohol and Other Drugs, and it's not very long. I really recommend it because it took a couple-year process to say, where are we? What's succeeding? And strategically, how do we move forward and reorganize the commission with that focus, now including harm reduction. So I think that that's why I put it in the bill on the doorways, that, the consensus was from HHS and other folks that this is going to be a long-term feature, and in one version or another, because it can evolve, we're going to need something like the doorways, but we need a point of access for programs that people can go to and get the help they need and be sent to the places that can give it. And that to me is an important model here. And the Doorways program is really willing to, expand to other places and expand its mission as needed and as appropriately funded, because we need them. We need them. Thank you.
Representative Nabel.
Thank you, Mr. Chairman. Thanks again for taking yet another of my questions.
Yeah.
One of the things I was struck with as I was reading through the bill was that the word misuse abuse was X'd out, misuse was put in. And it's a relatively another sensitive subject to me, but I'm just curious why that was done.
Thank you. That really throughout was at the advice of HHS, because this is the term that is now generally in use among providers and others. So that's why.
Huh.
I remember when it used to be the other term several years ago, and now this is what the field says is the appropriate language to use. So that's why HHS recommended we do that.
I'm sorry I'm making faces. They both terms have value and they're not the same thing. That's why I brought it up. So,
There we are.
all right. Thank you.
I hear you.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, harm reduction, following on Representative King, is a very broad term. And so as a newer member of the committee, I kind of struggle as to, where it begins and where it ends. It has some implied definitions in the bill itself. So I'm just trying to get a feel from you. Where do you kind of envision if the Doorways program is now empowered to go down this path as well? Are they going to be getting into housing assistance? I mean, so which could be considered potentially harm reduction. So what do you maybe see as the scope of it, or do you not have a full feel for that yet and waiting for the commission to kind of do some of its work?
Thanks for the question. And, if you're so right. My lens is like this, 'cause I've been so involved with it. And I, backing up and saying, do we need in statute a harm reduction definition? I'm not sure we do, but there are definitions out there. And certainly that was what was motivating the Governor's Commission and changing its mission to include it, was a kind of a consensus over what it meant in this context. Now, as Representative King's good question about, well, harm reduction can mean, everything, every ill that besets our society, we got to reduce the harm of it, right? And I get that, but I think that in this context, what we're talking about an accepted kinds of practices that reduce the harm that is involved with substance misuse. So that's what we're focusing on. And these practices, new ones evolve, but there are many, many practices. Harm reduction can be needle exchange. It can be wound kits. It can be safe sex kits. It can be clean water. It can be bandages. It can be naloxone. But see, the context there is for how do you reduce harm for people with substance misuse disorders. So that's, I don't know if I'm answering your question, but that's the surrounding logic.
So is the intention then that the commission would kind of flesh that out a little bit as it goes forward, bring that back to the budget task force, and then that would get some kind of further review later on? I'm just kind of trying to understand what the trajectory is on this thing.
Yeah, thanks for the question. And I'm sorry I didn't provide it to you, but I could, you can go online to HHS's website and go to the Governor's Commission, and you can take a look at the strategic plan. I said it's not terrifically long, so it's very readable, and you will find a lot of your questions answered there. In terms of funding, what the Governor's Commission is responsible for in statute is that the federal funding we get and other state funding, is kind of distributed through a grant-making process that is supervised by the Governor's Commission. So the Governor's Commission makes it gets the grant applications, it makes, from lots and lots of programs all around the state, and it apportions out the funding that it has. So harm reduction would be in that context of applications for use and the available funding and so forth. Now, the other issues about housing and these things, I mean, there are other folks working on that. But that's not appropriate for the Governor's Commission alcohol and other drugs.
So not within that. Okay, thank you very much.
Other questions? Yes, Representative Elberger.
Thank you very much, Mr. Chairman. Thank you for this excellent presentation. And just one quick comment, having started my work in addiction treatment as working in an alcoholism treatment agency where other drugs were not connected, I really appreciate that instead of saying alcohol and drugs, the language here is alcohol and other drugs because they are all in fact drugs. I'm not sure, in Ways and Means, we spent a lot of time working on the cannabis bill. And I'm wondering how some of the provisions in here about no harm and treating harm, preventing harm, connect with any of the provisions that are coming up in that bill.
Thanks for your question. The Doorways program does address folks who have issues with cannabis, and really comprehensively. Anything that somebody presents with, we're seeing a lot of increased meth around right now. So whatever you present with at the Doorways program, you will be referred to appropriate services. So that's another reason that whatever emerges, it's ready to take it on, and that's what harm reduction is about. Whatever emerges, how can we help reduce harm?
Thank you. Thank you, Mr. Chairman.
You're welcome.
And I'll say, Mr. Chairman, that a lot of the kind of inner workings of how HHS and these programs work, we'll get folks back here that actually know what they're talking about.
Someone from HHS has signed up to testify, so.
Yeah.
Other questions for the senator? Seeing no other questions, thank you. Oh, I'm sorry. Yes, Representative Kofal.
Thank you, Mr. Chairman, and thank you, Senator, for taking my question. So my question has to do with the section on page 4 that is stricken out. Use of general funds shall be prohibited unless otherwise appropriated. Is it, so I know Representative Leon asked a question about general funds before. Is this primarily because opioid abatement trust funds are, fit that description, and in order to spend those, we need to strike this language from statute? Or is this a general intention that, we're going to expand the program and sort of not let federal funding or opioid abatement funding, or the existence of that funding or the non-existence of that funding prevent us from continuing with these programs? I'm just
Thanks for your question. And the opioid abatement funding is in a fund. It's not general fund, right? So that is not what is directly here. Just a little bit of history. When, it took us two tries over 2 sessions to get the needle exchange program. And we didn't do that until, it was 2016, 17, whereas a lot of other states had done it starting in the 80s and 90s. And I hate to think of the cases of HIV and Hep C that, during that period, but there we were. To get that bill passed, and there was a lot of resistance at the time for all the reasons you might imagine, it was important to have that provision in there. I think that people have seen over the last few years the necessity of these programs. And so this bill does not appropriate anything from general funds. It just say that a future legislature will not have its hands tied if it seems appropriate to include some state funding to support syringe exchange programs. So that's precisely why just striking that means that future legislatures in the budget can have the option if they think that that's a good idea.
Other questions? Seeing no other questions.
Thank you so
Thank
much,
you,
Mr.
Senator.
Chairman, and I'm available if there are more questions.
Okay, great, thank you. Representative Weber.
Just before you go on, it might be useful for all of us to note that this is an early bill and it will go to, I assume, to finance afterwards.
That's my understanding, yes.
Thank you.
Okay, also signed up to speak is Jenny O'Higgins from the Department of Health and Human Services. I've asked for 3 minutes, and that's usually the rule for people testifying, so thank you.
Hello there. Thank you so much. Chair and members of the committee, my name is Jenny O'Higgins. I'm a policy analyst at the Department for Health and Human Services and Behavioral Health and your legislative liaison for these topics. So I just wanted to make sure to speak today to this bill. The department is in full support of the bill. It makes many appropriate language changes based on best practice in the field, as well as adding the potential of additional services and codifying existing services in the state that are critical to reducing substance use disorder and any community harms associated. What I did want to comment on today is that there is an attached fiscal note worksheet, which was submitted back in February. And since that time, our concerns have been corrected in the amendment in working with Senator Waters. And so we, have not had an opportunity to update that fiscal note worksheet. But the piece here that really was concerning initially was around codifying the doorway system that is all stood up through federal funding. And as you've heard already, that state opioid response grant is on a 2-year cycle, and the state does have to reapply every 2 years. So we're currently in the 3rd iteration of our state opioid response grant, and it does end September 30th, 2024, and the state will reapply again. We're currently receiving that $28 million per year on those 2-year cycles, of which the Doorway program is approximately $11 million. Additionally, we have 5 staff members that oversee that state opioid response program and continue to monitor those contracts. So our concerns had just been that financial burden without that funding. The funding is based on a federal formula, which is really based on 2 specific data points. One is the state's proportion of drug overdose deaths per the CDC, and the other is the state's proportion of people who meet a diagnostic criteria for dependence who report not having received treatment, which is from the National Survey on Drug Use and Health, and that those formula funds can change in each 2-year cycle of the state opioid response grant. So our concern would be having less funding, but needing to run the same program. I think the way that the language has changed both says that with availability of appropriate funding, we can run this program. The other thing that it does is that we actually changed just the very specific nature of how the doorway was defined to actually talk more about substance use disorder access points, which we will intend to have, fully behavioral health crisis system through all of our work in our long-term planning that may or may not include those federal funding formulas. So to the point, that was a question that was asked earlier about sort of longer term sustainable funding and how New Hampshire will do this work. This language change gives us more flexibility to make sure that we continue to integrate our substance use disorder care within our mental health, behavioral health system and primary care in long term.
Thank you.
I'm happy to take questions.
And any perfect timing.
Yes.
Any questions? Yes, Representative Nagel.
Thank you, Mr. Chairman. Thank you for taking my question. I want to, I hope, if you're not the right person, let me know, but I do want to get back to that same question about abuse versus misuse. To me, it's an incredibly important distinction. And in the Controlled Drug Act, it's actually abuse is defined, misuse is not defined, harm reduction is not defined. I'm just curious from HHS's point of view why it was important to make that change.
Absolutely. Thank you for your question. So people who experience stigma are less likely to access treatment and less likely to be retained in treatment and go on to get well, right? So our words and language have a significant impact on how people see themselves, and how people see themselves has a significant impact on whether or not they access care. And so we've done a lot to best practice language changes in order to make sure that we're doing stigma reduction. So the term abuse was found to have a really high association with negative judgment or punishment. And so the term misuse or use, it allows for an even more broad thinking than addiction or a substance use disorder. So substance use disorders are on a spectrum, and opening that more broadly allows us to also fund prevention and early intervention and to treat people long before they may even experience a full substance use disorder that meets diagnostic criteria.
Follow up?
So this is my concern. And my knowledge base is primarily opioids. So I'm going to limit it to that. But we know that there's 11 million cases of misuse per year. 70% of those, as defined by the CDC, are actually functionally self-medication. People misusing because they're not getting access to treatment for pain or whatever. That's where I'm struggling with the distinction, and I get the stigma thing totally. But I think we're dealing with two separate issues, and it may open up greater doors for us, but it may also restrict doors for us too. Opening, I probably should explain that, right? No.
Do you have a question, Representative?
Yeah, I want to I'm still trying to understand, how this is going to help when it seems to me that 70% of people is going to be harmed by this kind of distinction.
I think that's something where I'd be happy to work with you offline to either
Yeah.
define use, misuse, and abuse and how we think it would make the best sense to get the work done.
All right, that's fair. We've had this discussion a lot. Thank you.
Other questions? Representative King.
Thank you, Mr. Chairman. Thank you for taking questions. I've heard the term a few times already today, needle exchange program. But I'm looking through this bill and what I'm seeing is not syringe exchange program. I'm seeing the term syringe service program. So my question is, in order to get a new clean needle, is it required to exchange an old needle?
Simplest answer there is no. So the access to a new syringe allows for a reduction in all kinds of medical challenges, including infectious disease, endocarditis. And so that access is not restricted based on whether or not you turn in previously used syringes, which you may not have in your possession. The difference in all of the language pieces there with what you've said with needle exchange, syringe services programs, all of that, and harm reduction is that it's broader than an exchange of needles alone, right? Because there is also naloxone, there is also referrals to treatment services, there's making a connection with people and making sure they have many of the other supplies or things that they would need to keep them healthy and safe and reduce that harm.
May I have a follow-up?
Follow-up.
What requirement or requisite is required for an individual to get a new needle? So, for example, it's illegal in this state to possess, a hypodermic needle if you're just an average person. But if you show up to these service centers and you ask for a needle and we give it to you, under the assumption that you misuse drugs, what requirement is there on the person to prove that they actually do have a drug misuse problem?
Is it just access to healthcare broadly, essentially? So there's not a requirement to be able to receive services. It's very low barrier in order to help reduce public health harm.
Okay, thank you very much.
Thank you. Other questions? Yes, Representative Merchant.
Thank you, Chair, and thank you for taking the question. I want to commend everyone trying to expand harm reduction and dealing with misuse and abuse and things of that nature. But one of the key words in here that I refer to throughout this document is the word prevention. So what are we doing to prevent people getting on opiates in the first place? I mean, how is this commission helping to guide non-opioid therapy, drug use, if you will, to get them into other things that would be helpful to treating pain? Because the old saying goes, an ounce of prevention is worth a pound of cure. But what are we doing on the prevention side to help the patient, first and foremost, not even getting on the trail for opiate use to begin with?
Can I just clarify, with the Governor's Commission plan, is it specifically? Sure. So the Governor's Commission plan does have significant amount of prevention. I think prevention could always use more funding, I will say that, especially because there's not also the opportunity for things like insurance reimbursement on the prevention side, right? So it does take additional dollars to put into prevention programming to do it well. However, New Hampshire has done, a number of different programs, including our student assistance professionals, SAP program, educational programming, and youth, coalitions, drug-free community grants, all kinds of prevention programming and there is a specific report that comes out from the Governor's Commission as well that I'd be happy to provide you with to actually walk through some of the prevention efforts, and not to say that they're ever enough.
Follow up?
Thank you. And also thank you for the report. You hit, I think, the nail on the head. It comes down to is the patient doesn't have the insurance coverage for non-pharmacological therapy. And I'm just trying to find out from the governor's point of view, this commission, what kind of focus they're trying to do with the insurance industry to help patients, or maybe fund a pilot program so patients can seek, if you will, non-opiate therapy to help them with their pain. That's what where I'm trying to go to. Because right now the funding's not there. The insurance companies many times don't either reimburse for it or put a lot of barriers up for the patients to get that kind of pain control. So just trying to find out from the governor's point of view, since you're here, what is being done in that arena?
So I think that actually goes a little bit further than what I was thinking of when you originally asked about prevention programming, which I was speaking to is much further upstream around education for young people and that kind of thing. I think you're talking very specifically about pain management alternatives. Yes. So that's something that I can bring back and ask a question about to try to answer.
Thank you.
Sure.
Other questions? Representative King.
Thank you again, Mr. Chair. And thank you for taking another one of my questions. I think you may have been here when I asked the senator the question, and that is my concern is that this legislation is patterned after what we're seeing around the country, and the results are going to be just massive amounts of homelessness and violence and needles littering the streets and feces and just a nightmare. I don't want to see that. It used to be in this country that if you proved to be a harm to yourself or a harm to others, you went into the padded room until you got better. And what I see here potentially is just really kind of the cheapskates version of harm reduction. It's like, oh, we don't want to pay for them to go to the padded room, so we'll just give them the needles and the drugs they need and just kind of get them out of our hair.
Mr. Chairman, I'm going to object to the language.
My apologies. Does this seem like a very financial, inexpensive way to solve the problem, whereas the more expensive solution would be time to go into the padded room? Thank you.
Mr. Chair,
Yes.
that is truly offensive language, and I object to it strenuously. I hope you will rule that it shouldn't be used anymore.
Representative King, please be more considerate.
I'm not sure what was inconsiderate.
Representative Weber,
The use of the term padded room.
I'm not sure what the correct term is.
Psychiatric facility.
okay, a
it's
psychiatric.
something
Okay.
along those terms. So it's kind of slang use,
Okay.
very outdated and kind of offensive in today's mental
regarding
health
mental
community.
illness. Yeah.
Okay.
It's very demeaning.
So you may proceed with an
Okay,
answer.
thank you. So the way that we're offering care has actually significantly changed based on so much more detailed research. So what we know is that community-based care has better outcomes, and that residential facilities are needed for a very small amount of the population. And so what you're describing would be a residential facility. I don't think that we're moving care based on a financial decision. I think we're truly moving care into a way where we're meeting people where they're at to keep them healthy and well. And we're doing that, based on significant research and to provide better care with better outcomes, because people do well when they stay in their community.
Other questions? Representative Kofalt.
Thank you, Mr. Chairman, and thank you for taking my question. So I personally know someone who is a recovering addict who has benefited greatly from a methadone program. And so I'm curious to know if that is when we talk about, when we use the phrase harm reduction, my understanding is that harm reduction is, I mean, we've talked a lot about syringe service programs. Can you talk about some other things that are incorporated into that definition? And specifically, is something like a methadone program, does that fall under the category of harm reduction?
Sure. So harm reduction can be used very broadly. The way that I think about harm reduction is that I have my kids wear a helmet when they ride their bike. I have them, ride in a car seat. I wear my seatbelt. These are all harm reduction strategies, right? So it can be very broad. It can be all of the different types of things that we do to reduce harm. It's bug spray, it's sunscreen, and so anything that we can do to keep ourselves and our community members healthier and reduce fatality. Ultimately, when we get into this level of the kind of harm reduction that's being done, it's about reducing the spread of infectious disease, and it's about keeping people alive so that they have the opportunity to go on to get well. FDA-approved medications for substance use disorder, I would consider treatment. They obviously can also reduce harm, so I think it just depends on how you define harm reduction. But they would be considered treatment, and they would be reimbursable as well under insurance. So that is how I would personally answer that question, and I think people define harm reduction differently.
Representative Shapiro.
Thank you, Mr. Chairman. Thank you for taking this question. In regards to the question of whether people should be treated or be given the opportunity to reduce harm in the community versus going to a residential program or a hospital, et cetera, would you agree that we've already had a lot of experience with separating people in an attempt to help them with their problems by sending people to jail and sending people to prison, and that's been a dismal failure?
Yes, I think that entering into the criminal justice system does come with inherent additional risks. And so it can be very traumatizing for folks. And does, we now have done our criminal justice system, especially in New Hampshire, I think can be very proud of the work that they're doing to provide adequate care, and is very much invested in the work that we're doing with the Governor's Commission as well. I do, though, believe that there are just multiple pathways to recovery, just like with every other chronic illness, and that we need to trust that and respect that people have a say in their care as well. And so in the criminal justice system, it's, punitive because you've broken the law. When we're talking about treatment and harm reduction, we're talking about access to health care. And so it may be that a medication isn't right for you. It may be that a 12-step program is right for you. It may be that it's a medication and cognitive behavioral therapy. It may be that residential treatment. I mean, we're looking at, are there the efficacy and the outcomes of multiple different pathways to recovery? And in New Hampshire, we're looking to support them all.
Yes, Representative Cushman.
Thank you, Mr. Chairman, and thank you for being here and taking my question. You're talking about the different therapies, and we had a discussion on a previous bill. And did you email me the breakdown of the evidence on which ones are effective? And
no, I have not sent that, but I do have an overview of the treatments available for opioid use disorder and their efficacy.
okay, that would be great. A follow-up?
Follow-up.
Thank you. It has to do with this too. So when it sounds like we need a more narrow definition of harm reduction. And I'm hearing that it includes treatment, and then I'm hearing it doesn't include treatment. So, would you say that it's separate from treatment and that the harm reduction is solely based on a current user, treatment aside, who just we're trying to prevent the STD the bloodborne pathogen transmission and infections and things like that?
Yeah, I think the critical piece around including harm reduction in all of this work and writing it into the Governor's Commission and the funding and this bill is that it isn't reimbursable in the way that clinical treatment services are. So as we discussed earlier around prevention, the need for additional funding and diversified funding sources to make sure that our harm reduction programs can continue to operate is not dissimilar from those in the prevention area, right? And then when we're talking about treatment, we're talking about clinical treatment, and therefore there is also reimbursement rates in addition to any federal grant funds and things like that. So that's one of the reasons that it's so important that we make sure we specifically call this out, is for the reason of being able to keep them financially viable in the state.
Other questions? Seeing no other questions. Okay, thank you.
Thank you.
Also signed up to speak is Lauren McGinley from New Hampshire Harm Reduction. I've asked for 5 minutes. I'd appreciate if you could keep it to 3.
I will keep it to 3.
Thank you.
Thank you, committee, for having me today. My name is Lauren McGinley. I'm the executive director of the New Hampshire Harm Reduction Coalition. We operate 3 of the state's harm reduction programs. I'll clarify very quickly. I'm attempting to change my language from syringe service programs to harm reduction programs, only because syringe service programs utilize the word syringe, and we are looking to provide harm reduction relative to all types of substance use, including alcohol, smoking, snorting, things like that. We want to make those services as accessible to people who may not use syringes but still need the support of a harm reduction program in their life. And so my language gets corrected to harm reduction program instead of syringe service program. For this conversation, I mean them interchangeably, one and the same. We operate 3 of the state's harm reduction programs. We also support, advocate, collaborate, and help fund the 7 other programs that operate in our state throughout. We have good coverage. I think we could do better. And as we move into communities and help communities identify and build their own harm reduction programs, we work very hard to include an advisory committee of those community members, representative of a whole continuum of professionals, to help guide our work as we begin to offer services, educate providers, interact with treatment and MAT providers. We look at the continuum that currently exists, which is prevention, treatment, and recovery, and we hope to integrate some harm reduction practices into every section of that continuum. I applaud and appreciate that within this bill, it also gives us a seat at that continuum table. So now it is harm reduction, prevention, harm reduction, treatment, and recovery. Senator Waters and the Harm Reduction Study Committee listened to all of us when we said that one of the biggest issues that we have in continuing to do this work is the funding streams that we have coming into the state and the way the state is unable to currently fund these public health programs. I'd like to provide a little bit of clarification, and I'm happy to answer any questions too if people would like to revisit a question or need some additional information. Syringe service programs in New Hampshire all operate as an exchange. Some choose to operate on a +10 model, which means if you come with 0 syringes to exchange and have me properly dispose of, I am able to give you 10 syringes, and that is engagement. The most critical piece of harm reduction programming is engagement with people who are actively using substances. So that 10 can then be returned the next opportunity that they have for, again, +10. You bring me 10, I'm able to give you 20. The better coverage that we get within the regions that we serve, the higher rate of exchange, the higher disposal that we provide, and the lower numbers people need to sustain until that next point of interaction. So I will give an example. If a community has a syringe service program that operates once a week, those numbers need to go up in the amount of syringes and safe materials like wound care for that person to prevent infection, prevent the transmission of HIV, to prevent fatal overdose.
If you could start wrapping up, please.
Sure. So as we decide to spread out across the state, we look to those communities to identify how we do that and what fits best for their needs. So I'm happy to answer any questions. People had great questions.
Thank you. Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. I noticed when I asked Senator Waters about whether APRNs ought or ought not to be included in this, you were moving your head, and I didn't know whether you were saying they didn't need to be included or they did need to be included. So I wondered if you'd care to elaborate out loud.
Sure. Thank you for your question. Any prescriber, any DEA prescriber is allowed to prescribe some form of MAT. The largest restriction exists within methadone treatment, which still in our state needs to be administered within methadone clinics. But yes, buprenorphine, Vivitrol, Suboxone can be administered by any DEA prescriber. APRNs are included in that category. So yes, my suggestion would be to add them. I think proposed language could be any DEA provider. DEA prescriber, sorry.
Other questions? Sure, follow-up.
As a follow-up, would you agree with me that the problem of just using any DEA provider is that we need to get it somewhere close to the APRN statutes so that they actually know it rather than having it hanging out somewhere that they might not look?
I do agree with that. Yes.
thank you.
Naming all of them would be an ideal situation. Yeah.
Other questions? Representative Nagel, and then Representative Cushman.
Thank you for, Mr. Chairman. I actually have a really boring question. I assume your T-shirt has value. What does it say?
Thank you for the question. It says all bodies are good bodies.
That was the question?
I thought she wore it for a reason, and we should know what it was.
Oh, no, I'm sorry.
Oh,
Representative Cushman.
Thank you, Mr. Chairman, and thank you for being here and taking my question. Sorry, got distracted. Oh, you probably know the answer because I saw you shaking your head when it was mentioned. I believe it's only illegal in the state for a minor to possess a hypodermic needle. Is that correct? With some exceptions.
Yes, thank you for allowing me to provide clarification. The state of New Hampshire does allow any person over the age of 18 to have a hypodermic needle. I am able to walk into any pharmacy and purchase them. I am able to order them on Amazon. It is legal for anybody to have a hypodermic needle in New Hampshire.
A follow-up, sure.
And would you just, for me, step through that explanation that you were giving toward the end of your testimony about increasing the resources that you're making available? Can you just break that down again for me?
Sure.
Where you
yeah.
said I'll give you 10, you bring back 10, and then I'll give you 20.
Yeah. Thank you for that opportunity. So our 3 programs operate on a +10 model. So again, somebody brings me 10, if somebody brings me 0 and says, I need help, I'm reusing my needles. I'm buying needles off Craigslist for $5. I don't have access to clean and safe wound care. I can say, here's 10. Here's a wound care kit. Here's an overdose prevention kit, or what some would recognize as an overdose response kit. So naloxone, fentanyl test strips, a breathing mask. I can provide them with a whole kit of services to prevent infection, to prevent the transmission of HIV, and most importantly, to prevent fatality. The more opportunities that communities get to offer those services, the wider net you cast. Anybody that uses drugs that is trying to seek out our help deserves to have a window of time within their life to do so. And so when we have one time a week to operate, it really limits the amount of quality care that we can offer someone. And so we work with communities to expand access to harm reduction services throughout any kind of touch point that they may have, so that they can have, we call it the Swiss cheese effect. Some Swiss cheese has big holes and people can fall through them. So we try to shorten those holes so that people don't fall through.
One more follow-up.
Okay, so backtracking to if they come in with 0 needles and you can give them 10, and then if they come in with those 10, then you can give them 20.
Yes.
And then if they come back with 20, you give them 30.
Yes.
And where does that stop?
So it is budgetarily limited usually by the program. Our programs stop at 150. And I want to identify that no person utilizes 150 syringes in a week. What we have identified there is a person that is serving multiple people who do not feel safe or have the ability to access harm reduction programming in their community. We have had feedback from a lot of people that have said a harm reduction program saved my life, and I never visited one once because I was too scared, because of the stigma, because I was in danger. So when people come and are able to it's called secondary distribution, when they are able to acquire what they need and share with others what they need, those numbers start to really support multiple layers of infection prevention in a community.
Representative Nutter Upham, you all set? Yeah. I saw your hand up earlier. Any other questions? Representative McLean.
Just quickly, thank you, Mr. Chair. So I'm starting to, thanks to all this testimony, mentally understand the buckets of treatment, prevention, and harm reduction. And you mentioned that you had actually changed your name to New Hampshire Harm Reduction to basically say, just kind of clarifying this is what it is. So from respect of the definition, is that how the broader community really sees harm reduction? And do you see, if this bill was to become law, that the bulk of the harm reduction activity for those portions of the bill would be around that, and that's what it's talking about? Am I reading that correctly?
Thank you for the question. Yes, I believe I agree with you. This bill is comprehensive enough that it does cover our current activities within harm reduction, and it also allows for expansion within the regions that I believe you touched on earlier today. Connection to services for homeless individuals, connection to medical care for people that don't have it, connection to long-term recovery supports or legal assistance or financial assistance. All of those things sometimes fall under the purview of a syringe service program or harm reduction program because we recognize a person as a whole person, and accessing that treatment or recovery option can only happen once basic needs are met. So basic needs do fall into our category often, but this bill covers the practical strategies associated with harm reduction provision. Okay.
Any other questions? Seeing no other questions. Okay, thank you.
Thank you very much.
No one else has signed up to testify on Senate Bill 239. Does anyone else wish to testify? Comment, Representative Leon?
Thank you, Mr. Chairman. I just spoke with our committee researcher, and she will be able to provide us more information on the syringe program and on this background so that we can have more information ahead of next week.
Okay, thank you. Okay, if no one else wishes to testify, I'm going to close the public hearing on Senate Bill 239 and open the public hearing on Senate Bill 238. Senator Prentice is the prime sponsor, and I'd ask her to come forward at this time. Good morning, Senator Prentice.
Good morning, Chair McDonald and members of House, HHS, and Elderly Affairs. For the record, my name is Sue Prentice. I'm the state senator from District 5. I represent 15 communities, a large part of Grafton County, some communities in Sullivan County, as well as one in Merrimack County, the beautiful town of New London. I'm here today to introduce to you Senate Bill 238. So this bill would allow an essential practice in the care and treatment of mental health patients which was first established under our national COVID-19 public health emergency, and we want to have this remain here in place in New Hampshire. Once the national order public health emergency is fully rescinded in May, so will the ability to use telemedicine, telehealth, to continue to prescribe for mental health conditions. So specifically here, we're talking about the ability of physicians and nurse practitioners to prescribe, again, via telehealth, Schedule 2 through Schedule 4, controlled substances only for the treatment of mental health conditions. This had previously been done last year for substance use disorders. I think one of the silver linings from the pandemic is that we learned that there was a much wider use and acceptance of telehealth, and in particular in the area of treatment of Granite Staters who are experiencing mental health conditions. In the words of Dr. Roger Awesome, and he is he represents, or he's part of the Community Health Centers Coalition, and he actually is the executive director for West Central Behavioral Services, which has its home in Senate District 5. He is quoted, he's quoted as saying, telehealth has offered patients the capacity to participate in services they may not otherwise have been able to access. This can include older adults, people with mobility issues, those who are housebound due to family needs, or those who lack reliable or cost-efficient means of regular transportation. For them, telehealth has proven to be not just a convenience, but a welcome necessity. So, as I stated in the first part of my introduction, that we're up against a deadline in May when the National Public Health Emergency will be rolled back. So the ability for nurse practitioners and physicians to continue to prescribe via telehealth will cease to exist. We believe that I believe that this is a necessity, and so does a majority of the healthcare community and the mental health professionals who've come together behind this Senate bill. I want to make a few points as we move forward. You know, again, we're talking about removing a barrier and how valuable telehealth has been. Concerns have been raised during the Senate process that there weren't patient-provider relationships that were in person. And we have testimony from Dr. Mary Lou Tyner from the New Hampshire Psychiatric Association, who's also in the Community Behavioral Health Coalition, that there is a requirement for an in-person visit to start this process. So during the pandemic, if we can just separate off that time, it was unlikely that you were doing in person. Now it is required that kicks off or starts the relationship in order for this prescribing to take place. I also want to point out that you are looking at an amended version that comes out of the Senate. The amended version clarifies the language or clarifies consent for minors. So it's my contention that always existed, but the Senate, and I support this, wanted to make sure that it was, clear across the board that parental consent for minors to receive treatment for mental health conditions, and particularly prescribing, was clarified in the statute. And you'll also see that there was language added that had to do with access to a minor's medical records. So with that, I'm asking for your timely consideration due to the fact that we are facing an essential deadline here, and we want to continue to offer this service to patients to granted status who are experiencing mental health conditions, and rely on this as a way for access to treatment, access to healthcare, access to prescriptions when necessary. So I will close my comments there. I'm happy to answer any questions you have. I do have people behind me who who I know can provide further points of clarification. So that's it. Thank you.
Thank you. Questions for, yes, Representative Cushman.
Thank you, Mr. Chairman, and thank you, Senator, for being here and bringing this bill. Can you just tell me again where it clarifies that the initial encounter has to be in person?
The initial encounter, it's not written in this bill, it already existed. So we did not pull the language in here, but it was clarified by the Psychiatric Association that they have to have that patient-provider relationship. It exists in medicine as is, it just was different during COVID, that you couldn't prescribe to a patient unless you had a relationship with them. Thank you for the question.
Other questions? Yes, Representative Nagel. Then
Thank you,
Representative
Mr.
Murphy.
Chairman. Thank you for taking my question. I think I read through this bill about 100 times trying to solve my concerns. And I thought I'd solved them, but then you said something that changed my mind.
Ooh, okay.
Back. I know it's the purpose is mental health, but as we know, these medications have value well beyond the mental health realm. And what I'm concerned about is for me to do my job is be getting harder and harder because I have patients that are 200 miles away from me, and telehealth to prescribe an opioid is incredibly important. I want to make sure that this bill doesn't take away my ability to treat somebody's pain as opposed to a mental health problem.
Thank you for the question, Dr. Nagel. So it doesn't take away that ability. In fact, your committee has already considered House Bill 500,
Yes.
which is broader and is encompassing of all of this. So we had these two bills, mine that was more tailored on the mental health side as a follow-up to substance use disorder, and then we have HB 500. So I hope that helps answer your question.
It helps a lot. Thanks.
You're welcome, Dr. Nagel.
Representative Merchant.
Thank you, Mr. Chair, and also thank you, Senator Prentice, for taking the question. Speaking of House Bill 500, I believe it was heard by the Senate Health and Human Services Committee. Any thoughts on where that's going at this point in time? What I'm trying to get to, it sounds like it could be some redundancy between this bill and that bill. But if House Bill 500 is moving through the Senate, and you're absolutely right, we're facing a deadline by May 11th in order for us to not impact, if you will, current practice. So what happened on House Bill 500?
So thank you, Representative Merchant, and good to see you this morning. House Bill 500 has been heard by the Senate. It it has been heard by Senate HHS, which I sit on. We are not meeting this week. I know that it is under consideration, that we're talking about some of the same amendments that we discussed here in terms of consent, medical records, all of the necessary clarifications. So here's the bottom line, whether it's 238 or 500, and I think honestly, I mean, this is my bill, but 500 is the better vehicle because it is broader. And I think it does it serves the Granite State better. So these two will meet up. And I think the committee is well aware of the timeline that we're facing. You're welcome.
Representative Shapiro.
Thank you, Mr. Chairman. I have a question and a follow-up.
Sure.
My question is, I thought or I assumed that this bill applied to people of all ages, but then it starts off with talking about minor children and parents. So is it true that it applies to children as well as adults?
Thank you for your question. It applies to children as well as adults.
Okay. Follow-up?
Follow-up.
I don't see this as a full solution in any way, but could this be an incremental help in terms of the emergency room boarding situation where people could actually make contact with a provider by phone in an emergency rather than going in an emergency room in a crisis?
It's a good question. I don't think I can give a thoughtful answer. I mean, I worked in an emergency room that boarded patients regularly, and they have to present themselves in order to be triaged and managed appropriately. The telephonic replacement or substitution for that, I'm not clear how that would work given EMTALA, there's a few other considerations. So thank you for the question. I'd be happy to think about it and circle back to you.
Thank you.
You're welcome.
Representative Weber.
And my question is just jogged by Representative Shapiro's question. Thank you for taking the question, and thank you, Mr. Chair. I was wondering if the requirement of an in-person visit to start the process, which is already in our statutes, isn't that the barrier to perhaps somebody who's in crisis getting telehealth rather than going to the emergency room?
It would present a barrier. They have to start with an in-person visit. But there are, I'd like to defer.
Okay,
I want to make
that's
sure
fine.
that I don't mix the two up here. I mean, I think that Representative Shapiro has brought forward a reasonable, line of thinking about the fact that we have these crises and we have people that are boarding, and would not bringing them into departments, but triaging them before they got there actually prevent them from having to be boarded but receive treatment. That's what I believe we're talking about here, and I'm not sure exactly what the best way to manage that is. Okay, but thank you, Representative Weber. Just want more time.
Other questions? Seeing no other questions? Okay, thank you.
Thank you, Chair McDonald and committee. Good to see you all again.
Also signed up to speak is Lisa Mascio from the Office of the Child Advocate. You've indicated you need 3 minutes, and that's exactly what I was going to suggest.
Good morning, Chairman McDonald and members of the House Health and Services Committee. My name is Alyssa Mascio. I am the new Associate Child Advocate with the Office of Child Advocate. Our office is a independent state agency mandated for the oversight of child protection and child serving agencies here in New Hampshire. As part of that mandate, we are concerned with the protection of children and also the best interests of children. Our office had been looking forward to testifying in support of SB 238 as originally drafted, but unfortunately with the floor amendment, we are now in opposition of this bill as potentially interfering with children's safety and their access to safe and adequate care by providers. During COVID, we saw that mental health access was enhanced by telemedicine. However, we also saw a loss of trusted and reliable reporters for children, namely schools and healthcare providers. RSA 169C, the Child Protection Act, is intended to protect children, but also to look out for their best interest. We know that children sometimes have barriers to reporting unmet needs or dangers in their home, one of which is a lack of opportunity and trusted and safe adults. Healthcare providers, mental health providers, medical providers are one of those safe spaces, and we have significant concerns with sections 3 and 5 of this bill as amended, that by holding providers to a standard, a very high standard of not allowing a potential offender access to a child's medical records could really endanger children. Currently under 169C, the standard for professional child protection workers, assessment workers, and their attorneys with DCYF is only a preponderance of the evidence, a relatively low standard, just over 50%, to take children away from their parents. Here, we're asking healthcare providers who are not trained assessment workers, not trained to assess the safety of a child, held to a clear and convincing standard in order to protect a child's information and medical records from a potentially offending parent. We do feel like this very high standard in the amended language would interfere with a child's ability to access that safe and trusted professional, knowing that their information would be protected. Typically, a provider is a mandated reporter, so they would take that information, report it to DCYF, and allow the professionals to take over from there. And they would also have protection to use their best judgment when not releasing records to a potentially offending parent. This language changes all that, and we do have significant concerns for how that would endanger New Hampshire's children. I'd be happy to take any questions.
Thank you. Any questions? Representative Merchant.
Thank you, Mr. Chair, and also thank you for taking the question. The way I read through this bill, the onus is placed upon the provider or the individual has the record to protect the record per se. The onus isn't on the parent to go to the court to release the record. Is that correct?
We're looking more specifically at the subsection B3, where the healthcare provider is required to determine by clear and convincing evidence based on articulable facts when not to release based on a parent request. The section before that with regards to the court was not really something we were looking at. I think there are probably other agencies that would be dealing with the court aspect.
So the onus is on the provider to defend themselves versus what I'm trying to get to is the parent has a right, but that right should be governed through the court. Now, if the parent goes to the court and the court says they agree with the parent, would that also not allow for the release of the record? What I'm trying to get to is a balance between the child being protected from an abusive parent. So the parent, so if the court determines that there's no issue for the parent to have access to the record, at least it's going through a court in order to obtain the access. It's not putting the onus back on the provider trying to make that determination.
The concern is the initial determination for the provider to withhold the record in the first instance is a very high standard of clear and convincing. Otherwise, they would I would presume, feel they would need to release the record, which could potentially interfere with an investigation if the offending parent is getting that record in the first instance. I think court action would come too late, kind of let the horse out of the barn.
If we reverse that, if I may, Mr. Chair,
Sure. Go
if
ahead.
we reverse that and make it that the only time the record can be released is with a court order, it takes the provider off the hook because they're not having to worry about what they're trying to do to defend themselves and justify what they're doing. It's up to the court to make that decision.
Thank you for the question. I think the language is still not clear as to who would have standing to bring it to court, who's coming to court, and even which court. But again, I think there are probably other agencies that would deal with that court side of it.
Representative Weber.
Thank you. So have I understood correctly that you would prefer the language of the original bill, which is at least has the advantage of being written down somewhere, rather than this language?
Thank you for the question. I think the original bill with the intent simply to expand telehealth medicine for mental health purposes, the OCA is in support of. We saw during COVID just how helpful that can be and necessary for a lot of people, including children in our state.
Representative Shapiro?
So
Oh,
I'm sorry, could I have one more?
Sure.
I'm late here. So is the issue, I'm sorry, I didn't look at the Senate version, the original version. Is the issue here that this is language that was not in the original version? And has
Correct.
now been included? Okay,
Yes,
thank you
and
very
this
much.
language is very similar to SB 253, which I believe you are hearing next week.
Right, thank you.
Representative Shapiro.
Representative Weber asked my question.
Okay, all right, thank you. Other questions? Representative Cushman.
Thank you, Mr. Chairman, and thank you for taking my question. I just want to be really clear on where you're at with this. So are you saying that you would like children to be able to access telehealth, mental health, medication treatment without knowledge of parents or their consent on a blanket basis for every child?
The office's position is that the original bill language is something we would support. I'd have to see what alternate language you're suggesting. The way the bill was originally written, the OCA would support.
Other questions? Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So follow up on what Representative Cushman is asking. So help me understand. So if we already have limitations for abusive parents, like what other situations are concern for you? Is it like about prescribing puberty blockers that you want to do with original bill, or is it like maybe some vaccination prescription? And if parent is vaccine hesitant, so what are other scenarios aside from abusive that you are trying to avoid by opposing this bill?
Thank you for the question. I think the office's concern is with the way this bill language is worded that would interfere with the medical provider's ability to focus on providing medical care and instead be having to worry about assessing a child's safety when deciding. Parents already have the right to access to children's medical records under the law. It is with certain carve-outs. This law creates an onus on a medical provider, very high standard of evidence, in which cases they would not release records to a parent or guardian. What those specific concerns would be case specific, and the Office of Child Advocate does believe that should be left to the provider's reasonable judgment, not to this very high standard that would interfere with their ability to provide appropriate care to a minor.
Follow-up?
Thank you for taking my follow-up question. Can you understand me bigger picture? So we are saying that most parents are good parents, but some are abusive or otherwise interrupting with what's good for medical care and safety of kids. Could the same be told about medical providers, or is there anything that your Office of Child Advocate would try to protect from cases when there's some abuse from medical providers.
I'm sorry, I don't think I understand your question.
It's okay.
Representative Weber and then Representative Leon.
Thank you again, Mr. Chairman, and thank you for taking my next question, which is, am I correct in thinking that the bill as it originally stood made no change in the existing law about access to children's medical records? So it not only did not further restrict, did not expand access for parents, but it didn't restrict access further for parents either. It simply left that part of our current statute intact and allowed whatever could be done in person, allowed these things in this statute that could be done in person also to be done by telehealth.
Thank you for the question. That is my understanding. It is my understanding that parents already have a right to access under New Hampshire law.
Thank you.
Representative Leon.
Thank you, Mr. Chairman, and thank you very much for being here and providing your testimony, both written and in person. My question to you is that it's my understanding that all these providers are mandatory reporters, and so if they have a concern about the parent, that should be part of their involvement in the exam. And if they believe that the child is in an abusive situation or otherwise at risk, isn't that something that they're already looking for when they're interacting with these children?
Thank you for your question. I am not a medical professional, so I can't speak to specifics as far as medical ethics. But yes, frankly, every adult in the state of New Hampshire is a mandated reporter. As I said, one of the most frequent and trusted reporters are healthcare providers, and their obligation is to report their concerns to the agency, to DCYF, to conduct a professional investigation by trained assessment workers. As far as what their obligations are to record it within their notes, I'm sure there are others here that could speak to that obligation specifically.
As a follow-up, I guess my question here is if there's been a report made to DCYF, wouldn't that be sufficient to note in their notes that they had a concern about the child's safety and therefore they were referred to DCYF? And that would be a more than adequate indication that they believe that that child was at risk?
In order to not release the records to the parent?
Yes.
I do not believe that's what this language says. Clear and convincing is a very high legal standard, and as well as needing articulable facts and have it fully documented, essentially putting a medical professional in the place of a safety assessment professional, which they are not. So again, I couldn't speak to as far as what a medical professional's requirements are for their documentation, but I used to be a DCYF attorney. Reports that come in do not rise to the level of clear and convincing. That is not the job of the reporter. It's the job of the agency to investigate. And in fact, as I said, 169C, the standard to take a child away from a biological parent in an abuse and neglect proceeding is only preponderance, not clear and convincing. But we're asking that medical providers somehow have evidence rising to clear and convincing at the outset, not a professional investigator. So there's a discrepancy there that could lead to barriers within that relationship and harm children.
Thank you. That was definitely more detailed.
Thank you.
Other questions? Representative Weber.
Thank you, and thank you for the telegraph, Representative Helberger. So I have two, if I may. One, I think trying to get at the nub of perhaps Representative Palazov's question, because I think this reporting, although not directly related by the bill, is very important to it. Isn't it true that if anybody, a parent or other medical professionals think that a medical professional is harming a child in any way, then they must report the medical professional, presumably both to DCYF and their professional licensing board.
Thank you for the clarification, and I'm sorry I didn't understand that initially. Again, all adults in New Hampshire are mandated reporters to the division as far as child abuse or neglect were concerned. I wouldn't be able to speak to what ethical obligations that one medical provider may have to report to the medical board, but certainly all adults are required to report any abuse or neglect they suspect.
And
Follow-up.
and it's not quite a follow-up, but with regarding the issues of standard and proof, we have clear and convincing proof. And that means that you actually have real, am I correct that that's real and true evidence, as opposed to the second level, which is preponderance of the evidence, which just means that there's more evidence that abuse is there than there is evidence that abuse isn't there. Is that right? I've probably phrased that inartfully as to the preponderance standard.
Generally, preponderance is just over 50%,
Yeah.
not a terribly, it does require evidence.
Right.
But clear and convincing is substantially higher than that. To put it into context,
Right.
as I said, 169C requires preponderance to take children away. It requires clear and convincing to terminate a parent's parental rights.
Right.
Much higher.
Oh, that's very helpful. And then one final question, which is, and isn't it true that the reporting level is much lower than that? You just have to have a suspicion that it's happening, and that requires you to report. Is that not true? A suspicion that a child is being abused to report, to require that you have an obligation to report. You don't have to be able to prove it.
Thank you for the question. The Office of Child Advocate would like to believe that everyone understands the standard to be low. You should always call the division if you have a concern. The Child Advocate's efforts are to protect all children. So the standard should be as low as possible to any suspicion. That's why there are trained professionals to then investigate and ensure that that child is safe.
Thank you very much.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman. In terms of the urgency related to the May 11th end of the emergency, isn't it true that we're only talking about Schedule 2 through 4 medications? I didn't know what those were really until I checked with our resident pharmacist, and that most psychiatric medications can be prescribed by telehealth, whether we pass this bill or not.
Thank you for the
That only a
question.
subset, like stimulant medications, will not be allowed to be prescribed.
I am afraid I do not have expertise in that area either. I would also defer to your resident expert for that.
That is correct.
Other questions?
It's just Schedule 2, 3, and 4.
Any other questions? Seeing none, thank you.
Thank you very much for taking the time to hear me.
Psych drugs are Schedule 5.
So antipsychotic medication, antidepressants, that's all.
Also signed up to
It
speak
doesn't
is
have
Matthew Hood from
Don't have
Dartmouth
full
Health.
potential. So like, stimulants, benzodiazepines, things like that.
Xanax.
Yep. That's this.
Thank you very much, Mr. Chairman. Members of the committee, for the record, my name is Matthew Hood, Vice President of Government Relations at Dartmouth Health. I apologize for the raspiness of my voice. I'm on the tail end of a cold. Hopefully I'll
Good that you're sitting way out there then.
wait. I'm settled way over here. Exactly right. I will be brief. We support Senate Bill 238. As Senator Prentice said, we've seen the value of telehealth, including telehealth prescribing during the pandemic and beyond. Think about the context of the workforce shortage, which continues into today. That didn't go away when the pandemic concluded. And with respect to timely access. As I read 238, it enables telehealth prescribing for mental health practice. That is in addition to the current statute, which allows for telehealth prescribing for substance use disorder. That's where it ends. To Representative Nagel's question earlier, House Bill 500 flips the paradigm, and it allows telehealth prescribing for everything. That includes cancer care, that includes post-surgical pain management. That includes palliative care. My colleague was here last time, if you remember, for 500, who was in the palliative care space. And so I would be remiss if I didn't say, reiterate my appreciation for this committee's work. Representatives Leon and Merchant in particular are working on an amendment on that bill, which passed out of this committee 20-0, and then on a voice vote out of the House. So thank you for that, and I hope we see 500 come out of the Senate as well quickly. What else would I like to add? That's really what I wanted to make sure that I reiterated for the committee. I did want to speak, though, to two other points. One is to the safeguards that exist with respect to prescribing. We had talked about the DEA proposed guidance that has come out. So when May 11th rolls around, what is it going to look like? And the DEA guidance requires in almost all situations the establishment of an in-person relationship with a patient before prescribing. And then, of course, New Hampshire statute also requires a visit as is appropriate for the patient or the condition, but no less than once a year. So there are safeguards around this prescribing via telehealth that I felt it was important to comment on as well. Finally, I will say that for 238, the consent provision that you have that was added by the Senate in terms of consent for a minor to be prescribed medication via telehealth, we worked with the Senate on that language. We're very comfortable with where that language is right now, and we're happy to work with this body, should it be so inclined, on the access to medical records component that was added also by the Senate, but which we find currently a bit problematic in that it's inconsistent with federal requirements as we understand them. So I will end there and happily take questions and appreciate your consideration.
Thank you. Yes, Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. Now I'm nervous again. It seems to me critical that both 500 and 238 pass or my goals aren't achieved. Am I wrong about that?
My answer to your question, Representative, and I think anyone people would agree with this behind me if they're going to testify subsequently, House Bill 500 does everything and more than what Senate Bill 238 does. So Senate Bill 238 is great. It extends it to mental health, but that's it. And so 500 covers a much broader swath of practice areas.
I'm sorry, follow up?
Follow up.
Would there be any opposition from your mind about adding, we could refine the language, I think, but for pain management, to have that specifically in this bill?
I would hesitate to go down the road of enumerating practice areas in which you can prescribe via telehealth, to be honest with you, Representative. I'd be much rather inclined to do what House Bill 500 did, which was to say you can in this situation, because you'll leave something out, with all due respect.
Well, you're right. Thank you. Thank you.
Representative Leon and then Representative Weber.
Thank you, Mr. Chairman, and thank you very much for being here. So it's my understanding that you believe that House Bill 500 is sufficient and that this bill, if 500 passes, is not necessary?
With all due respect to my friend, Senator Prentice, yes, I believe that that's correct.
Thank you.
She knows that I was going to say that, I think, so, yeah.
Representative Weber.
My question was asked and answered. Thank you.
Representative McLean.
Yeah, just kind of a procedural question. Do you think there is any way where this legislation or HB 500 might actually end up creating an environment where those folks that desire the in-person interaction may have their access limited in that regard, because we're moving, due to resource constraints, more and more to telehealth, and that's, you might find people saying, actually, we're going to curb down this, and actually it's only available to telehealth. Do you see any scenario where that might come to pass through legislation like this?
That's a great question. Thank you for the question, Representative. My inclination at this juncture in time is that the answer would be no. And the reason for that is because we want to be patient-centered. If a patient wants an in-person visit, they're going to get an in-person visit. If they want a telehealth visit, and there are many reasons for wanting a telehealth visit, we'll try to accommodate a telehealth visit. It's more about, for me, we saw a spike in telehealth services at the beginning of the pandemic, and then a drop-off and a leveling off of it since that point in time, since the spike. And so for me, this enables access for those who might have a hard time getting for an in-person or not wanting an in-person, but it's not going to replace in-person care. We're not at that point yet.
Other questions? Seeing no other questions. Okay, thank you.
Thank you very much, Mr. Chair, members of the committee.
Also signed up to speak is Sam Hawkins from NAMI of New Hampshire. And again, 3 minutes, please.
Good morning.
Morning.
Thank you for the opportunity to testify today. For the record, my name is Sam Hawkins. I'm the Public Policy Assistant at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI, I'm here today in support of SB 238. It's no secret that New Hampshire is amid a mental health crisis. In New Hampshire, 221,000 adults have a mental health condition, including 57,000 who have a serious mental illness. Further exacerbating this crisis, Granite Staters struggle to get the help they need when they need it, due in part to New Hampshire's workforce shortage. Providers can't meet our state's level of need through current channels. Telemedicine is one crucial tool to be used in addressing this issue and increasing access to mental health services, especially in rural areas of the state. As you heard earlier, during the pandemic, several emergency orders were issued which expanded telemedicine. These emergency orders allowed providers to provide all medically necessary services remotely. When telemedicine was passed into state law last year, it contained restrictions on the prescription of certain medications. SB 238 would codify a more expansive prescribing law for mental health conditions, thereby putting into statute parts of the emergency orders from the pandemic. Telemedicine expands access to care for all and is well suited to many of the challenges those living with mental health conditions may experience. Through supporting the mental health workforce and lowering barriers to care, SB 238 would go far in addressing the mental health crisis in our state. I urge you to vote OTP, and thank you for your time. I can take any questions.
Thank you. Any questions? Okay, seeing no questions.
Thank you
you
very
very much. Also signed up to speak is Laura Condon from Bedford. And you have 3 minutes, ma'am.
Good morning. Thank you for the opportunity to speak. My name is Laura Condon. I'm from Bedford, New Hampshire, and I oppose Senate Bill 238 relative to the use of telemedicine to treat mental health conditions. I've provided a couple of handouts for you. This bill will permit physicians, surgeons, and nurses to prescribe Schedule II through Schedule IV drugs considered dangerous by the U.S. Drug Enforcement Administration. You are correct, Representative Shapiro, that other drugs still could be prescribed via telehealth, but these are scheduled dangerous drugs for very good reasons. These controlled drugs can be very dangerous, even deadly to the person prescribed the drug, their family members, schoolmates, and coworkers. People who seek these drugs should be carefully evaluated and monitored in person. This is not the time for telehealth. It is dangerous. One face-to-face visit for children is neglect. More monitoring is needed. Children, and this is no limit. This could be infants, toddlers, preschool children. There's no limit here. They develop at a very rapid rate. We owe them the requirement that they be seen more frequently than one established visit, and then additional drugs and a cocktail and dosages up and down can be done simply via telehealth. These scheduled, and the handout I provided you is from the Diversion Control Division, and it shows the scheduled 2, 3, and 4 drugs so that you could be more familiar with them. These are drugs that have high potential for abuse and may lead to severe psychological and physical dependence, and include such drugs as oxycodone, fentanyl, morphine, amphetamines such as Adderall, methamphetamines, methylphenidate, and phenobarbital. For your information, phenobarbital is a sedative that slows the activity of the brain and nervous system and is commonly used to euthanize pets. And since 2010, 14 states have used phenobarbital in state executions. These are very dangerous drugs. Just how dangerous are these prescription mind-altering drugs? Well, they're deadly, in fact. In January of this year, there was a woman, she was a nurse, Nancy Clancy in Massachusetts. You may recall that she strangled her 3 young children, slit her wrists, slit her throat, jumped out a window, paralyzed herself. She killed her children. This was not some sort of street drug addict. This is a well-respected nurse who, in postpartum depression, was prescribed a cocktail of 13 different drugs. It made her crazy. Her children are dead. Lives are ruined. The risk of suicide in children and adolescents being treated with antidepressants is well-established science. The Food and Drug Administration requires black box warnings and have expanded that warning over the years. Monitoring of children requires face-to-face in-person interactions and observations that cannot be done via telehealth. As many who are treated for depression are prescribed a cocktail of drugs that would include the mix of the class of drugs included in this bill. Provisional data from CDC's own records show that during telehealth, there was a 4% increase, I'll wrap it up, 4% increase in suicides during this period of time. Clearly, telehealth is not working. This bill neglects to protect children from aggressive and dangerous prescribing of ever-changing cocktail of psychotropic drugs, shamefully only requiring consent from a parent once. Irrespective of how many prescription doses are changed or new drugs are added to this cocktail, there is no evidence of safety of these cocktails of drugs. I proposed in the handout an amendment that would provide protection for minor children, and I ask that you carefully consider that. I think we owe our children protection of these scheduled drugs. We recognize that mental health treatment should be more readily available. There are many safe methods of treatment, including counseling, behavior, exercise, even
Again, please wrap up.
to improve health. I urge you to oppose Senate Bill 238 as written or amend it with protections for children. Thank you very much for your time. Happy to address any questions.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman. Thank you for taking the question.
Sure.
I really share some of your concerns about people being over-medicated, having multiple medications, especially children. I don't know of any evidence to say that that has been done more over telehealth than in in-person visits. In fact, my experiences with a lot of people, a lot of children and adults who have mental health issues who've been put on a myriad medications through in-person visits. So I'm not really sure how the issue of telehealth or not telehealth is related to those concerns.
Thank you very much for your concern. And there was, and I have it in the handout, that the CDC does report a higher incidence of suicide during this period where we've used in telehealth. Is there something exactly points to telehealth itself as being, the pivotal change here? We've got this nurse who killed her children, on 13 different psychotropic drugs. I think it's very clear that we would want more monitoring of children, not less, in spite of the fact if we haven't done studies yet. It just makes sense. They need to be carefully monitored in person. Thank you.
Thank you. Other questions? Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. Can you a little bit expand on monitoring and on benefits of in-person monitoring versus telemedicine monitoring? Maybe there are some situations when telemedicine would be better if a doctor can spend more time chatting with a client, or do you think that certain side effects from medication and certain mental health conditions could be detected only in in-person visits? Thank you.
Thank you, Representative. I think if I understand your question, what are the benefits of in-person, versus telehealth. And when I first looked at telehealth, I thought, well, it's a Zoom meeting, right? So the doctor actually gets to see them. If you look at the definition of telehealth, it doesn't have to be. And in testimony, I was on the Senate side, it could be an email, it could be a text message. So there's no visual contact with the patient necessarily via telehealth. And we all know, we've done the Zoom. And even with Zoom, we all know that there's something really different about sizing up a person and to evaluate, how they're doing when you actually get to see them in person. Is this child looking really tired? Are they disheveled? Were they actually able even to get to the appointment? Is their life in chaos? And those things, I think, you get a better sense of those when you see someone in person. Is it the parent pushing for this, to try to control their child? Just a lot of information can be gathered from those in-person visits to protect children. Thank you.
Thank you. Other questions? Representative Palmer.
I guess my concern would be this. During COVID and during bad weather, the choice often is a visit or no visit, not telehealth versus an in-person visit. So I guess I would just like a comment. I mean, wouldn't a telehealth visit be better than no visit at all?
I think if there's a crisis situation, that an in-person visit, absolutely is required. I don't think if a person's in crisis and just because there's a snowstorm that you can add a drug. So I'm sorry, did I misunderstand your question?
Well, my question is really if the choice is an in-person visit, a telehealth visit or no visit, not necessarily a crisis situation. We're talking with this, it's getting a prescription done. So the person is going to run out of their medication. They can't get to their in-person visit. Isn't the telehealth better then?
Thank you. I think I better understand your question. And you'll see in the amendment that I proposed is that a refill of existing prescriptions would not require an in-person visit. So if it's, that sort of routine thing, but I think we owe children the protection. If you're increasing dosage, decreasing dosages, adding additional drugs, the drugs aren't working, those sort of things require an in-person visit. But yes, some situations, and that's why I put that in there, simple refill, shouldn't necessarily require an in-person visit. Thank you.
Other questions? Seeing no other questions. Thank you.
Thank you very much. Thank you all.
Okay, also signed up to speak is James Monahan from New Hampshire Community Health Association. You said you only need 2 minutes. So you're entitled to 3.
Thank you, Mr. Chairman. My name is Jim Monahan with the DuPont Group, and I'm here today on behalf of the Community Behavioral Health Association, the state's 10 community mental health centers. I can only take 2 minutes because I want to focus mainly on 2 things. I agree with Matt Hood that Senate Bill 500 does everything and more that 238 does, and should Senate Bill 500 be enacted, there's probably not a need for 238. And thanks to the hard work of this committee to address the issue in a more comprehensive way rather than an issue-by-issue way. I am concerned, as I'm sure the committee is, because you took the time to change the effective date on 500, that we are running up close to the deadlines on the public health emergency. I think there's a senator in the room, so I'll be careful, but that delay is very much, somewhat in the hands of the Senate to try to address that now. And so anything that this committee can do to move that along, I think would be helpful. Senate Bill 238 was proposed to the Senate Health and Human Services Committee on February 15th. The Senate had the hearing. They amended the effective date and passed it on the same day. It was on a good cost to get taken care of in a timely fashion, but it did get hung up in the Senate on some of the issues associated with Senate Bill 253, which is crossed over. I think that's now in the possession of the Children and Family Law Committee. That's probably a better place to deal with a lot of these very appropriate questions around parental consent and access to records. And so it's been a little frustrating that this bill and this topic has been hung up on that. You all don't have any control of that. I would hope that should you proceed, you're certainly going to take into account that Senate Bill 500 addresses that. We'll be working in the Senate to try to get that bill out of committee on the Senate floor to the House for concurrence and to the governor all by May 11th, which won't be easy, but we'll try very hard, and we may be back to ask for your help on that. So I'm talking more about process than the bill, but if you have any questions on the legislation, I'm happy to do what I can to answer them.
Okay, thank you. Any questions? Representative Leon.
Thank you, Mr. Chairman, and thank you. Did you say Senate Bill 253? I just wanted to make sure I wrote that
I
down
think
correctly.
I have the number right.
Okay. My computer's not loading, so
People are not correct, yes. And am I right? It's in Health, Children and Family Law? Yeah.
thank
Great.
you.
Other questions? Seeing no other questions. Okay, thank you very
Great,
much.
thank you.
I have no one else signed up to speak for Senate Bill 238. Does anyone else wish to testify on Senate Bill 238? Seeing no one, I am going to close this public hearing on this Senate Bill 238. That concludes our public hearings for today. We are going to be going into executive session and considering a number of other bills for which we have already had public hearings. So thank you all.
5 minutes for the back.
Sure, and we'll take is 5 minutes enough, or you want 10?
10 would be very.
All right, we'll have a 10-minute recess. like to reconvene at this time, and we're going into an executive session. There were 7 bills noticed in the calendar for today, and I would like to proceed pretty much in the order that they're listed. First one would be on Senate Bill 50, relative to pharmaceutical drug take-back programs. Do I have a motion on that bill? Representative Cushman.
Thank you, Mr. Chairman. I move that we vote ought to pass. I put a motion for ought to pass.
Okay, is there a second? Representative Palmer seconds. Would you like to speak to your motion, Representative Cushman, or?
Sure. Let me just pull it up for me. Sorry, just sitting
Bill
down.
Palmer.
This is the prescription buyback. This is enabling us to move away from putting our used medications or no longer prescribed medications or medications left over from patients who have been discharged or died in healthcare facilities like nursing homes. So we can stop using the yucky goo that creates mold, and it's a really nasty way of getting rid of these meds. And this is just a nice, clean way we can give them back to a pharmacy.
Okay, thank you. Any other discussion on this motion? Representative Merchant.
Thank you. Recently, the DEA has now required that pharmacies, not saying not to support the bill, but just to give people an update on what's happening on controlled drugs. Anytime an opiate is dispensed by a pharmacy, they're required to actually give the patient or the caregiver something to dispose of medication. So it goes back into trying to broaden the issue of ability to dispose of controlled drugs to keep them out of the supply chain, particularly the patients. So I support it.
Thank you. Any other discussion? Okay, seeing none, I'll ask that the clerk call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative King. Bill
Yes.
King, and
Sorry.
actually, I'll go first. Yes. Representative Kofal,
Yes.
Representative McLean.
Yes.
Now you're up. Representative Seth King.
Yes.
Representative Mazur.
Yes.
Representative Nagel.
Yes.
Representative Polozov.
Yes.
Representative Weber.
Yes.
Representative McKay.
Absent.
Absent. Representative Freitas.
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Merchant.
Yes.
Representative Elberger.
Yes.
Representative Palmer.
Yes.
Representative Priest.
Yes.
And Representative McDonald.
Yes.
19, 0, and 1 not voting.
If there's no objection, I'd like to put this on the consent calendar. Okay, moving on.
Was
I hear. Okay. Representative Cushman, you'll be doing the report on that? Okay, thank you. Moving on to Senate Bill 83. Do I have a motion? Representative Cushman.
Yes, I move that we ought to pass SB 83.
Okay, thank you. Do I have a second? Representative Shapiro seconds. I'm sorry.
It's okay.
Representative Cushman, do you wish to speak to your motion?
Yes, thank you. This bill is pretty common sense. I think it's been a long time coming. Just allows the APRNs and certified nurse midwives to sign in place of a physician on anything that's within their scope of practice. And I hope you'll support the ought to pass motion. Thank you.
Thank you. Any other discussion? Representative Nagel.
I would just add that it basically is bringing statute into reality, because for the most part, this all already exists. So it's important that statute meet reality.
Thank you. Other discussion? Seeing no other discussion, when the clerk is ready, I'll ask that you call the roll.
Representative Leon.
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Polozov,
Yes.
Representative Weber,
Yes.
Representative McKay, no vote. Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Elderberger,
Yes.
Elberger, I'm sorry. Representative Palmer,
Yes.
Representative Priest,
Yes.
and Representative McDonald,
Yes.
19-0.
Okay, again, if there's no objection, we'll put that on the consent calendar. Moving on to Senate Bill 34 relative to the Controlled Drug Prescription Health and Safety Program. Do I have a motion?
I have an amendment.
Oh, okay.
Does everyone have the amendment?
It's almost all around. It's working its way down that
Thank you.
side.
Make a motion to approve the amendment, to move it?
You move Amendment 1352H to pass, I assume?
Ought to pass. Thank you.
Okay, is there a second? Representative Leon seconds. Representative Merchant, would you like to speak to your motion?
Yes. The reason for the amendment is the fact that when we looked at the bill initially, it says the commission may authorize the program. And in speaking to the Department of Health and Human Services, my concern was within the department is accountability. If you leave it open to a program, a program cannot sign a document. A person can. So at that point in time, we're talking about release of information. I wanted to be sure that there was some traceability back to a person who has the authority granted to them by the commissioner. So if something inadvertently goes wrong, we can go back to that individual and saying, you released the authorization. You had the authorization to release the information, but you shouldn't have authorized it. So I wanted to be clear to the department that we have traceability and accountability to an individual, somebody that we can trace to being authorized by the commissioner. That was the only reason for making the changes. In the department, I worked with them in collaboration, and they support the amendment.
Great, thank you. Other discussion on the amendment? Seeing none, I'll ask the clerk to call the roll. The vote is going to be on the amendment 2023-1352H.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Polozov,
Yes.
Representative Weber,
Yes.
Representative McKay, not here. Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Elberger,
Yes.
Representative Palmer,
Yes.
Representative Priest,
Yes.
and Representative McDonald.
Yes.
19-0, one not voting.
Okay, do I have a motion on Senate Bill 34?
I'll make a motion to ought to pass as amended.
Okay, Representative Merchant makes a motion on Senate Bill 34, ought to pass as amended. Is there a second? Representative Leon seconds. Any discussion? Seeing none, I'll ask that the clerk call the roll, if he's ready.
Representative Leon,
Yes.
Representative Cushman,
She stepped out.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay, not here. Representative Freitas,
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Elberger,
Yes.
Representative Palmer,
Yes.
Representative Priest,
Yes.
Representative McDonald,
Yes.
makes it 18-0.
Okay. Again, if no objections, we will send that to the consent calendar. Okay, next up is Senate Bill 236. Do I have a motion? It is relative to Health and Human Service, establishing a committee to study nonprofit organizations contracting with the Department of Health and Human Services for Children's Services. Representative Leon.
Thank you, Mr. Chairman. I move an expedient to legislate.
Okay. Is there a second?
I'll second.
Representative McLean seconds. Oh, I'm sorry. Okay, Representative Mazur. Discussion. No, Representative Leon, do you want to speak to your motion?
Yes, thank you, Mr. Chairman. I appreciate the motivation behind this study committee. However, I do have some concerns about adding yet another study committee when we're looking at talking about insurance coverage, which is outside of the scope of this committee. I believe that this is something that can adequately be dealt with in discussions and ad hoc committees, and therefore this is unnecessary.
Other Representative Shapiro.
I hate to disagree with my colleague. Having been on a couple of study committees, one of which was the study of ACEs, which I thought was so incredibly broad and brought so many people to testify who were interested, and that this particular issue that was brought to us is so narrow that it actually, at least given my experience, is perfect for a study committee because it's a very narrow question that can bring limited number of people together and come out with a very concrete solution or recommendations for solutions. So I agree that there's, the issue of there being a lot of committees and difficulty appointing people to them is an issue, but I just thought that this was kind of the perfect, this was the perfect committee.
Representative Weber.
Thank you, Mr. Chairman. I agree with Representative Shapiro, and I will just add that these organizations are the organizations that provide services to our most vulnerable children. But if they cannot find affordable insurance, which was the underlying problem, they will either stop being available, and we already know we have a shortage of people available to do this kind of work, or the price will go up, and we know who's paying the price tag for that. So on behalf of our taxpayers and our children, I'm going to vote against the ITL.
Representative Nagel and then Representative Nutter Upham.
I agree with everything you said. Superficially, when I saw this bill, I wrote "Y" in huge letters on front of it, and I everything that the good representative here and I have ever done was all done on an ad hoc basis, and I think we got a lot of great stuff done that way. The problem that the one gentleman that testified was we tried to do it and they wouldn't listen to us. And that was the only reason why the bill was brought forward. If he hadn't said that, so if there's an alternative way to, put a fire under people's backsides to bring them together to discuss it. I agree with everything you just said, but he's saying that that's not the case. So that's
Representative Neto Upham.
So, when I read this bill, I didn't quite get it. And when the gentleman who testified said it wasn't about insuring the children, it wasn't the children's insurance, it was all the agencies that work with highly volatile and children, that they're not able to get insurances. So, Nashua Children's Home, I'm making that up. He didn't list the organizations. Waypoint. So if they can't get insurance, they can't treat any of these children. So the state of New Hampshire would be way out of luck with what to do with these children. And so the gentleman who testified, I'm sorry, I can't remember his name, he wanted the weight of the legislature to help with getting all the, what do we call them, shareholders in place so that we could have a serious conversation and figure out a solution to this. So I know we have too many study committees, and I'll volunteer to serve on this one, as I do with something that I am passionate about.
If it
So
ultimately comes into being and the speaker asks me to make a recommendation, I'll remember that.
absolutely. And I've been stuck before, so I've served on
And the
many
guys on either side of you know that does happen. So
Yes,
both
yeah,
Representative
and
Shapiro
I'll
and
volunteer. So,
Representative Nagel know that.
after-
So does
and-
Representative Merchant, although that didn't work out.
I know.
Sorry about that.
But Representative Lane, I think maybe you weren't here for that testimony, and it was compelling. So I'm if I could vote twice for this, I would.
Representative Merchant.
Thank you. I've worked on several ad hoc committees, and I think the real time things have worked through an ad hoc committee is when all the stakeholders are there because they want to be there and they want to do something and take some sort of action. What I heard Representative Nagel talked about it, they've tried that and it's not working. So I'm not really a strong supporter of committees and commissions and so forth. We have enough to begin with, but I think sometimes Representative Shapiro's point of view, this is narrow, it's very specific, and I think it's a way to bring the stakeholders together with the power, if you will, of this body about the importance of it to get something accomplished. Because I think ultimately it comes down to being able to care for the children. And if they can't get the insurance, we're going to disrupt it. So therefore, I would vote against the ITL and vote ultimately to pass it.
Representative Mazur and then Representative, okay. Representative Mazur.
I have in my notes from that hearing, specifically, a question was asked about a committee sunset date that I don't believe there was ever, we'd never resolved that. So if anyone's heard anything about that?
Go ahead, sure.
Thank you. I actually reached out to OLS earlier today, and because this is chapter law, not statutory law, it automatically dissolves after the report is filed. So we don't need to have a sunset provision on that.
Thank you. Thank you.
Okay, Representative Cushman.
Thank you, Mr. Chairman. I'm just going to support my colleague, our vice chair, on her motion. I think I do feel for the organizations who are having trouble with the insurance, but I think that they would do well to work directly with representatives who are willing to help them on some specific legislation. And if some stakeholders do not want to participate, the ones that they've been trying to participate with, who wouldn't entertain it, then they would miss out on the drafting and the crafting of that legislation. And we really need to reduce study committees. I've already voted for several this term, and I typically have a rule that I don't want to create study committees. So I will be voting against.
Representative Leon.
Thank you, Mr. Chairman. While I wasn't here in person, it was a very nice break to watch our footage from our hearings to interrupt why I was out of town. So I was able to watch and observe. One of the things that I found with my limited, but with my experience in the House, is that we have study committees and they also can't compel anybody to come and testify. So while they do have a little bit more weight of the legislature, they still rely on people's cooperation. And I've found that ad hoc committees often end up coming in with more buy-in than study committee results as well. So while I appreciate that this could add some heft, I know that I've seen very, very solid, very strong efforts come from an ad hoc basis. And I don't think, I appreciate their concerns and their challenges, but I don't know that this would actually solve that problem.
Representative Weber.
I will just refer back to the history of this issue and the fact that I think we have, somebody has put in a bill to address this problem, I think twice before already. And sometimes it's a limited liability bill, and sometimes it's an insurance bill. But the fact is that we have tensions between the cost of insurance on the one hand, the desirability of the services that are being provided, and some of the solutions which have been to limit liability, which then leaves some people without a remedy. So the stakeholders are not just DHHS and these care providers. It also involves things like the Trial Lawyers Association. And people have been working on this for some time now without a result. And so just saying that we're going to do that again and hope it works doesn't work for me, which is why but I share all the concerns that have been expressed about study committees. I do truly believe that, but I think this one is one that's worthy.
Representative Shapiro.
I just want to make the point that in regard to this debate, it's really about whether a study committee process would work or an ad hoc get together would work. And I just want to make it clear that I think nobody's accusing the other side of this debate of not caring about kids or not caring about those agencies being able to take care of kids. And I think we're all on the same side, that this is an issue that would be really important for us all to solve, both from a financial point of view, but also from the point of view of giving kids the best care. So none of us know which way it will get solved or if it'll get solved, but I think I'm going to vote against the ITL. But
Representative Weber.
And I just had one further point that I wanted to make that hasn't been made before. This also, it's not a huge committee, it's not a huge commission, it's 2 members of the House. And we already have one person who said they wanted to work on it, and 1 member of the Senate. So it's not a huge use of legislative resources.
Thank you. Representative Pofalt, did you have your hand up?
I did. Thank you, Mr. Chairman. So, having just started work on the Committee on Commissions, I am acutely aware of the number of study committees and commissions that, and I think this is at least the 3rd rendition of the Committee on Commissions in the past 2 decades. So, I guess my concern is expanding the number of committees and commissions, in this case, study committee, but also the effectiveness of that group and the likelihood that the recommendations coming back from that group will be implemented. There is an alternative that I would like to just put on the table for your consideration, which is that it is within the purview, my understanding is that it is within the purview of standing committees to address these kinds of issues, and whether that be sort of an ad hoc working group going off and sort of doing some legwork, or formally, and then formally undertaking work as a standing committee, or just starting it as the standing committee, bringing stakeholders in to examine this more closely. In terms of effectiveness, I do believe that if we had that level of participation, which is to say this entire committee participating in that process, we would stand a much higher chance of actually implementing the recommendations coming out of that committee, that is, this committee. So I'm going to vote against, I'm going to vote in favor of the ITL motion, but I wanted to offer that as an alternative.
Representative Nagel?
I know I'm not supposed to ask this question, but what did the Senate vote on this?
Oh, for it to have made it here, obviously.
I'm just
they
curious
passed
if it was close.
I don't know what the vote was. Representative Elberger, did you
Yeah,
know the answer to that?
When
or-
I was, yes, I was looking all the bills up, and they voted ought to pass with an amendment by a vote of 5-0.
Thanks.
That would be the committee.
You know what the,
Can I get a clarification from Representative Kofold about what he's suggesting? I'm not sure I understand what he's suggesting as an alternative.
Go ahead.
What I'm suggesting as an alternative is that this committee take on the work that is outlined in the bill. And the specifics of how that looks could vary. It could be that we meet as a committee and invite stakeholders in, or it could be that we delegate to a working group in preparation for this committee, holding more formal hearings in that context.
Representative Weber?
And I would say I have seen that process work. The question is what we're trying to achieve here. Having served on a previous iteration of the Committee on Commissions, or the Committee on Committees, one of the things we did was we made the rule that chapter law will expire at the end of the term that we're all sitting in. So this is not going to proliferate. It's not going to hang around doing nothing. It's not going to be an ongoing issue. That's item number one. Number two, if you are concerned about the use of the resources of this body, this uses 3 people. And I have a hard time getting behind the use of 20 people when a smaller number could do the legwork. So I guess what I'm saying is I would prefer to pass this study committee, but if it is not passed, my preference would be for the chair to appoint a small ad hoc working group, which is then an official committee. It has to notice its hearings, so it's not just people who self-select who they're talking to. Obviously, there's some stakeholders who may choose not to come, but then as Representative Leon says, they don't get included, and that's on them. But a small ad hoc committee would have to do its work under the provisions of the right to know law, and therefore would have, anybody who has an interest would be on notice and able to come. I mean, they can come anyway, but that way they know about it. So that would be my second preference, would be to have a very small ad hoc committee that is named by the chairman and therefore a subcommittee of this committee.
Okay, thank you. Representative Leon, and then Representative Merchant, and then Representative Shapiro.
Thank you, Mr. Chairman. There's definitely been some really good and important points here. I'm wondering if it would make sense for us to retain this so that we can do that ad hoc. And by doing that and having it based on our disposition at the end, if our ad hoc committee comes up with something, we could have a hearing on that non-germane amendment in order to get that into the January session so that we can, if we can find progress on this and if we can make something happen with that ad hoc group, we don't have to wait as long. This would actually accelerate it beyond the time frame of that study committee, because it seems like we all understand the need for this and we just simply haven't been able to get from A to Z yet. And perhaps this will give us that opportunity.
Representative Merchant.
Thank you. So I'm be clear, I understand this correctly. Representative Weber and also Representative Copalt and Leon. So it wouldn't per se be an ad hoc, it'd be actually an official subcommittee of this committee. So if we retain the bill, and the chair elects to create a subcommittee, which then has to go through public noticing in 91A, we're still in essence creating a legislative body that's going to pull the stakeholders together. Is that how I understand it?
Representative Weber.
Yes, although we have actually generally referred to those committees as ad hoc committees, which may be the wrong term for it, but I chaired one once. And I would say I think that this actually makes really good sense in the sense that we can get some people going. I think the one issue with the ad hoc committee is that it might be very useful to have somebody from commerce on it, and I'm not sure we can do that. But I suppose they could have their arm twisted up behind their backs or something. I would have to ask the clerk if it can be an intercommittee thing. I know that you can appoint some as a subcommittee of this committee, but
The speaker would have to do that, right? Appoint somebody from another committee?
I'm just not sure whether we have the ability to do it across committees or not. And I think, I just don't know. So.
Representative Merchant and then Representative Nuttarappam. I mean, Representative Shapiro.
I was really going to say something similar, which is I'm agreeable to this as a solution. It doesn't seem that different, but that this committee doesn't necessarily have all the areas of expertise that is called for to solve this problem. So I think, either voluntarily participating or being officially appointed to this subcommittee, I think we need people from who are more well-equipped to deal with insurance issues.
Representative Nuttarappam?
I was just going to say, we can always invite someone from another committee, whether they're officially appointed or not. Can't we?
Representative Nagel?
The reason I like ad hoc committees is that we're all equals. And I think that has a huge amount of value. But the other thing we do too is we reach out to everybody to make sure they're there. And I think that if I like this approach the best. I think it's a great idea. But my big concern is that we really need to make an effort to reach out, not just say, here's a notice and hope you come type thing. Because I know I've seen some really bad legislation passed because certain people don't show up, partially because they didn't know about it or whatever. But I think we do need to make that effort. And that's my only concern.
Thank you.
Mr. Chair, can we move the question?
We just found out that we cannot put someone from Commerce on the committee. We've checked with the clerk's office.
I was just about to send that off, so thank you.
Thank you, Christina. Other discussion? All right, what's the, Madam Representative Leon?
I'd like to withdraw my motion in order to make another one.
Okay, and then is the second withdrawn?
Representative Mazur.
Representative Mazur, do you withdraw your second?
Oh, yes.
Okay. Representative Leon?
I would like to move that we retain Senate Bill 236.
Is there a second?
Second.
Representative Merchant, I believe? Seconds?
Yes.
Okay. Any further discussion on this? Seeing none, I'll ask the clerk to call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay, no vote. Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nuttarappam,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes. Yes.
Representative Elberger,
Yes.
Representative Palmer,
Yes.
Representative Priest,
Yes.
and Representative McDonald.
Yes.
19-0.
Okay. Very good. No, hey, that's good. That's good. I suspect if we had stayed with ITL, there may have been a few. So. Fortunately, that's not on the docket today. All right, moving on to Senate Bill 30, relative to membership of the New Hampshire Council on Developmental Disabilities. Do I have a motion?
I'd like to make a motion that we ought to pass this bill.
Okay, is there a second?
Second.
Lucy, Representative Weber seconds. Representative King, do you wish to speak to your motion?
Yeah, I'll be short. This is essentially a short bill that just, it adds in, it subtracts not more than and adds in at least 21 members. And if I remember right, Representative Weber calculated that they needed 22.5. And it also removes the language of vacancies shall be filled by the unexpired term. So this is pretty straightforward bill. And so I ask that you vote out to pass.
Thank you. Any other discussion? Okay, seeing none. When the clerk is ready, I will ask him to call the roll. Motion is ought to pass on Senate Bill 30.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay, no vote. Representative Freitas, Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Elberger,
Yes.
Representative Palmer,
Yes.
Representative Priest,
Yes.
and Representative McDonald.
Yes.
19-0. One no vote.
Wow.
Okay. No,
Consent, Mr. Chair?
yeah, if there's no objection, we'll put that on the consent calendar. Next up is Senate Bill 32, relative to the opioid abatement trust fund. Do I have a motion?
Can I do it? Am I allowed to do it?
Sure.
Make a motion ought to pass.
Okay, Representative Nagel moves ought to pass.
Second.
Representative Merchant seconds. Representative Nagel, do you wish to speak to your
Sure.
motion?
This is my commission, commission, whatever it is, council. So I've been on this very short period of time, but one of the reasons I actually ran for office was to get on this commission. I think it has an incredible amount of value, but what was really neat at our last hearing, which I'm still having incontinence over because I actually had to chair the meeting, which I'd never done before. But they were very nice and we got through it. But what the point of the meeting was to bring together a lot of relevant governmental organizations together to solve a problem together. And that's partially what this bill does. The other thing is it just adds a lot of information on how we can do that the best we can. There's going to be roughly $300 million that needs to get dispersed to important organizations within the state. And for us as a group to do that by ourselves would be really challenging. The other thing that's really important is getting this money out as fast as possible. And the way it's structured right now, that's not going to happen. So there's a lot of organizations that need this money to do their job to facilitate everything we talked about earlier today: prevention, treatment, harm reduction, on and on and on. There's about 10 different categories of things that we're going to be looking at. There's 17 actually in statute right now. So it's a start, it's not a finish, but it's an important bill, and I would beg you to please vote ought to pass.
Thank you. Any other discussion? Representative Leon.
Thank you, Mr. Chairman. And this is absolutely a very important bill. The discussion earlier today did raise one question in my mind. What is harm reduction, and should that be defined in our statutes? I'm wondering if people would be amenable to just pausing this until next week and seeing about potentially adding a definition of harm reduction, because I don't want the equivalent of sunscreen to be using up valuable dollars that should be paying for things like syringe exchange and doorways programs and all of those.
May I answer? Yeah.
Representative Nagel.
It's unfortunate I didn't bring all of our materials because in the governor's information on their, I'm sorry, I'm getting all my nomenclature mixed up as to what's a task force and what's that and the other thing. But anyways, there's a long description of what harm reduction is, and I have absolutely no problem with tabling it, and I can share that with everybody here, and you can see what it says.
Representative Weber.
I would also say that, I'm sorry, I've got the wrong bill in front of me. I beg your pardon, but I think, let me pull this one out. If there's somebody else who wants to speak, take them and
Sure.
I'll look while
Anybody,
I'm.
anyone else? Representative Palazzo.
I want to confirm what previous speakers said, that I think it's an important bill in right direction, but I think we need to take steps to make sure that funds are appropriated appropriately where they need it. So I'm not ready to vote for it today, but
So you would
hopefully-
prefer to see it pushed off till next week? Or
yes.
Can I respond to that?
is that the pleasure of the body? Seems to be.
Well, Representative Nagel wanted to respond.
Representative Nagel, I'm sorry. Go ahead.
The process by which all these different organizations are vetted is unbelievable. And now what this would add actually is another level, that anything that we approve has to not only be approved by the Opioid Abatement Commission, but it also needs to go through the Governor's Commission as well. There's some of the smartest people on the state working in these two organizations, and I understand that concern up to a point, but that issue was raised right from the very beginning when this commission was started. One of the reasons I wanted to be on the commission is my people are neglected, and I wanted to be part of it to make sure that they were included. So, but I would be, if you want, I'd be happy to share the information on how this commission works, how it was created, what all the steps that it needs to go through to have a program be approved, where the money comes from, where it goes. It's a totally separate amount of money. It's not coming out of the general fund. It's not coming out of taxes. It's coming out of basically, trying to think of a plate word to call it, but money from, lawsuits from pharmaceutical companies. And it will be about $330 million. And that money has got to go to somewhere in a reasonable time frame.
Okay, I mean, would you be amenable if that's what?
I'm fine with waiting a week. The more knowledge is power. I mean, I'll be honest, to get ready for our last meeting, I read through all this stuff. I was really amazed, and I think you should see it because it's germane to everything we do here. I mean, it wasn't just about drug abuse and things like that. It was about the mental health, the 10-year mental health plan. It was about the 10-year opioid plan. It was really impressive. And I think if you all saw it, it'll help us do our job better going forward, because I think most of us don't even know about these things. So I don't think it's unique to this bill, it's to everything we do.
Representative Merchant, then Representative Shapiro, and then Representative Weber.
Thank you. I support this for several reasons, a lot of things that we've talked about. It does provide a clearer guideline to how the funds get distributed and dispersed. But also remember, it's not just what the legislative body wants to put on constraints. There is, I'm sure, within the settlement agreements, constraints within those agreements and how the funds can be utilized. So regardless of what this legislative body wants to do, the real constraint is going to be what's in those contracts that were signed between the parties on how the funds can be utilized. So therefore, I'm sure within those constraints, there's a limitation to what they can and cannot be used for, if you will. So I think trying to micromanage it at this point in time beyond what's already there in those contracts, which I'm sure were fully vetted, I don't think there's a reason to hold it up.
Representative Shapiro.
I'm ready to vote for it now, but I'm also okay with voting on it next week. But I think we have to clarify that if we're going to do that, it's because someone's going to bring in a specific amendment, not that we're just going to get more information with a definition of harm reduction, which I think was I think there were several of them given earlier, but I think we shouldn't have too much trouble doing that.
Thank you. Representative Weber.
Thank you, and thank you a lot for allowing me the time to rummage through my papers. I do think that the issue of a definition of harm reduction is very relevant to the bill we heard earlier today, but I don't think it's relevant to this one, partially because of what we've heard from everybody about the way everything is set up. But we need to also remember that although it says that the commission is going to award grants and revolving loan funds and matching funds, it also says that all disbursements or grants shall require approval of the governor and executive council. So for people who are rightly concerned about who is dispersing the funds and whether they are duly elected and whether they answer to the general public, these all require 2 levels of involvement already. And given the very extensive statutory scheme that already exists, I would be hard put to vote for a specific definition of harm reduction, which I think then muddies the waters rather than clarifying them. Aside from whether I agree with the actual definition that people come up with, which I think is going to be a sticking point. So I have no objection to putting it off for next week and letting people try if that will make people more comfortable. But I'm certainly much more inclined to vote for the bill as it is.
Thank you.
Thank you.
Representative Nagel.
You actually simultaneously gave the solution and the problem. We've had about, I don't remember what dollar figure number of grants already approved that are sitting in the executive council now waiting to be approved. So the time, so it's a roadblock and it's a solution at the same time, but it's important and it does exist. So as far as harm reduction, if I can also say that, I mean, I just got back from a meeting in Dallas. I mean, we could have sat for hours and days to talk about harm reduction. I don't think we're going to come up with a solution to that within the next week. I mean, now that we're creating new committees and ad hoc committees and things like that, I mean, at some level, that's already being done. But at the same time, it's something for us to maybe think about, because some of these committees that testified before us are already talking about those things. So I'm sure they have data information about it. But I don't think we're going to solve that issue in a week.
Representative Cushman.
Thank you. I was just looking at the bill, and it is possible that we could pass this today and then bring an amendment to the bill we heard earlier today, because they're in the same section, and we could define it there and it would apply to both.
Okay. Other discussion? I guess the question is, do we want to move forward? We have a motion on the floor right now about to pass. Do we want to proceed with that motion, or Representative Leon?
Thank you. I just would feel, I feel a little nervous about making it a very large blank check. I know it's checked by the executive council, but I have this gut feeling where I'm just not comfortable with that. If we can wait till next week, I can see what language we're also doing then. Otherwise, personally, I'm going to need to vote against the ought to pass, because I only want to support legislation I feel very comfortable supporting. I'd prefer to be able to vote for it, but I'll go with the will of the committee.
Representative Weber.
And I just want to make the point that this is already a much larger bill than harm reduction. I mean, it's already a much larger fund and than harm reduction, so that trying to micromanage one small piece of it with a definition may make things considerably more difficult rather than less.
Representative Nagel.
There's actually 17 different elements to this in statute now, and that's only one of 17.
Representative Leon.
I guess it's a matter of whether it's my no today or a possible yes tomorrow. I'll go with whatever all of you guys would rather have me say.
Well, again, we have a motion on the floor. I guess Representative Nagel, in a way, it starts with you. You'd have to withdraw your motion. So you want the vote to go forward, okay. All right, so there's a motion on the floor, vote to pass on Senate Bill 32. Any other discussion? I'm seeing none. I'll ask the clerk to call the roll.
Representative Leon,
No.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
No.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
No.
Representative Weber,
Yes.
Representative McKay, no vote. Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Elberger,
Yes.
Representative Palmer,
Yes.
Representative Priest,
Yes.
and Representative McDonald.
Yes.
16-3,
Okay.
and no vote, one no vote.
I'll write the minority report.
Okay, sure. Okay, and obviously it'll go on the regular calendar. Okay, and then the last bill for our consideration today is Senate Bill 35, which is,
Can I ask a question?
oh, sure.
The motion, Representative Leon, you would go with retain, maybe?
I'd go with, I'll need to draft the amendment, but it ought to pass as amended.
Okay.
Which one are we talking about?
On Senate, on 32, the one where I'm writing the minority report.
Oh, okay. Okay, so again, the last bill this morning for our consideration in executive session is Senate Bill 35 relative to RSV vaccine administration. Do I have a motion? Representative Cushman?
Thank you, Mr. Chairman. I have an amendment here. I move that we amend House Senate Bill 35 with Amendment 2023-1413H.
And you have copies of that? Okay. Okay, you made a motion, was that seconded?
I'll second.
And Representative Leon seconds the motion to vote to pass on Amendment 1413H. Representative Cushman, do you wish to speak to your motion?
Yes, thank you. So as we expand authorization to administer more and more vaccines outside of medical settings, first we started with pharmacies, optometrists soon possibly. That's a medical setting, but it's not traditionally where you would expect to receive a vaccine. We need to ensure that these other professionals that we're bringing in to do this are doing this safely and with proper training and properly follow up, especially when we're authorizing them to give vaccines that are very new. In 2021, Rep Merchant and I worked together on the language in RSA 318:16B, which is where SB 35 is making changes. And we agreed that if we were to authorize pharmacy professionals to administer vaccines outside of medical settings, there needed to be some safeguards in place. So we required some technique on some training on recognizing and reporting adverse reactions, injection technique, and we also included a requirement to comply with RSA 141C:20F regarding the vaccine registry. That's all well and good. Unfortunately, we found out during testimony on HB 1606 in 2022 that pharmacies were dropping the ball on informing patients that they had the right to opt out of the vaccine registry, and they were sweeping the private medical information into that government system without consent. So already we had some failure there on the part of these, on the part of the implementation of this new authorization for pharmacy professionals. And I don't mean any offense to pharmacy professionals, but the laws are, especially federal laws, they're written strongly in favor and support of vaccine manufacturers, as I see it, and it often results in harm to the privacy rights and even at times to the health of patients. And so it was good that HB 1606 passed, and hopefully that issue with the registry is solved. However, there remains the issue of low reporting of adverse events following vaccination. With this bill, we're authorizing pharmacy professionals to administer vaccines that aren't even on the market yet. They're very new. It's important for post-approval surveillance of new vaccines to have good data so safety signals can be caught early and dealt with and prevent further harm. And we do know, we do that through VAERS, the Vaccine Adverse Event Reporting System. It is not a perfect system, but it's the only one we have. And one of the things that makes it not so perfect is that vaccine adverse events are grossly underreported. There are analyses finding that the true number of reactions are 10 to 100 times higher than we have in the system. Even though medical professionals are required by federal law and in our New Hampshire statute, pharmacy professionals are required to report adverse events to VAERS. This amendment adds an enforcement mechanism. Basically, we're authorizing you this additional scope to your practice, and we expect that with that, there will be responsibility in following through with the requirements. And if they can't be upheld, what's in statute, then the authorization to administer vaccines for an individual who was authorized by this statute will be revoked. The Board of Pharmacy already has the authority under 318(5)(a) to accept complaints and revoke this authorization, but this makes it clear that this is the consequence for not reporting those events. And there's a 60-day window. Within 60 days, they just have to make that report after they become aware of a patient experiencing an adverse event. And they're very specific. They're listed, and the pharmacy professional should know all of this information. It's listed on VAERS. There's a table of reportable events for every vaccine, and there are also vaccine manufacturer contraindications. These are all things that you would expect someone administering these would be aware of. So they get that 60-day window to put the report in because it can be timely. And from what we see, it's pharmacists are not usually the ones who do find that someone has had an adverse reaction. It's usually another professional. But while we have this here, if it does take place and they are aware of it and no report has been submitted, they then have to submit it if they want to continue to administer vaccinations.
Thank you. Representative Merchant.
I'll speak against it, but I also want to address some things. First of all, I've enjoyed working with Representative Cushman on the vaccine bill 1606 in trying to address the concerns that were raised. Let me talk about some of the concerns I see with this amendment. One is the Board of Pharmacy, as she stated, currently has authority to discipline a pharmacist if there's something that they don't do that they should be doing. That's where the appropriate authority resides, to discipline a professional, back to the licensing board. Number two, it creates a double standard. Why do pharmacists have this requirement, but physicians don't, PAs don't, nurse practitioners don't, anyone else out there who's given vaccines, why they don't have the same requirement placed upon them? I'd be willing to work with Representative Cushman to deal with that issue more broadly and not talk about it narrowly. Number three, under the revocation, the way I read it right now, it's permanent. There's no recourse. You can't say to somebody, well, you're going to have your ability to immunize somebody for 90 days. Is it? Because at this point in time, the way I read it, it's permanent. There's no authority by the board to reinstate the license. Number 3 or 4, adverse events many times don't occur at the time of administration. So you may have a patient comes into the pharmacy, you immunize the patient, they sit there for 30 minutes, whatever time you think. So a lot of adverse events are not immediate. They happen 3, 4, maybe a day or two later. They're not going to be there at the pharmacy. So how is the pharmacist going to know that an adverse event happened if they're not actually the one observing it? And most of the time, if a patient has an adverse event, I would say they're going to call their primary care doc, they're going to call somebody in the medical team, not go back to the pharmacy. So for all those reasons, I think the intent of this is well intended, but because of the things I talked about, discipline is already there by the Board of Pharmacy. Somebody can call the board, make a complaint, happens all the time. It creates a double standard. We have a standard for pharmacists, but we don't apply the same standard to other healthcare professionals. 3, there's no way to undo the revocation. It's permanent the way I read it now. And 4, many adverse events that you want to be reported don't happen at the time they're in the pharmacy. They're happening subsequently, and therefore the pharmacist would not know about it, but they're now required to report something that they would not be aware of. Therefore, I can't support the amendment.
Representative Shapiro. Sure, Representative Leon, Cushman.
Sorry. So it says that they have to be aware of it. So it's once they become aware of it, and as long as a report hasn't already been filed. So if they aren't aware of something, there's no way that they can report it. If it goes to another medical professional, then that medical professional should be the one to report it. But if you're having a conversation with your pharmacist and you say, last month after my flu shot, I've had this lump on my arm that just won't go away, and the pharmacist doesn't report that, then I think that would be an instance that this bill is here for. The pharmacist would then ask, did you file a VAERS report, or did anyone? And if they find out that none has been filed, then it should fall upon them to file it, because they are the first point of contact, and especially if after they were the ones who administered it. The board does have the authority to discipline, but it is permanent for a reason, because this is an extra authorization that we gave, and I think that the consequence needs to be serious, because these reactions are very serious. People die from vaccine reactions. People become sick for life. And I think the laws are largely written in favor of protecting vaccine manufacturers. And if pharmacies are very fast paced, and I think that it's easy for things to slip through the cracks, and we need to really send the message that this is very important, and it's a requirement if you are going to be authorized to administer them. They won't necessarily have any action taken against their license. It's just this additional authorization that we've given these professionals. That individual won't be able to do it anymore. So that was deliberate. And as far as a double standard, these rules, under 318.16b that we worked on, I mean, we set these up, and they're not in place for the other professions. It was a double standard then, and we worked on that together. And the reason is because this is a new area where these professionals have a new scope added to, or a new authorization added to their scope of practice. And I think it's important because they may not always be in this situation where they're used to doing this kind of surveillance. So it needs to be here. And I would like to see it, added to other professions too. If this is a problem across the board, let's deal with it. We have this in front of us now. We want to add more vaccines, to authorize them to do these vaccines. Fine, but let's just put the safeguard in place.
Representative Shapiro.
Thank you. I share some of the concerns that Representative Merchant has, but on the other, I also have a considerable amount of thinking about that this is a problem that should be addressed. And I have a confession to make that I had the COVID vaccine and I had an adverse reaction, and nobody said anything about reporting it. So that was a little bit confusing to me. Eventually, I reported it. One of my questions about the specifics of this amendment is that the last sentence where it says failure to, where it talks about the consequence for not submitting a report, who would actually have, whose authority to provide these vaccines would be revoked? Would it be the pharmacy? Would it be the pharmacy tech who gave the, would it be the person or would it be the organization?
It would be the person. It says anyone authorized to administer under the section, and the section authorizes pharmacists, pharmacy interns, and licensed pharmacy assistants. Sorry, pharmacy technicians.
And who would have the jurisdiction to make that decision, to keep
To
track of
implement
it?
The Board of Pharmacy under the parent section. It's 318:5-A is where they have the ability to make rules and apply disciplinary action.
Representative King.
Thank you, Chairman. My question is for Representative Merchant. If you were hypothetically a pharmacist and you administered a vaccine, and I think you're right, 99% of the time it's going to be right then and there. But if you did see somebody experience an adverse reaction, why wouldn't you report it to VAERS? Is there some financial burden or time burden that would make it prohibitive, or I just don't understand? Thank you.
No, I would say if you are with a patient and say the patient came from a physician's office and it was 3 or 4 hours after the visit, and you talk to the patient says they're thinking of having an adverse event, you should be at that point in time reporting it because you're the one aware of it. The question at that point in time is that as the pharmacist is dealing with the patient, you're encountering with them, if they're hearing from the patient about a concern and that concern elevates it to a point of being an adverse event to a vaccine, they should be reporting it. It doesn't always have to be the vaccine that you gave. It could be the vaccine someone else gave you, becoming aware of it. So under the board, if you are become aware of any adverse event to a vaccine, regardless if you gave it or not, you should be the one reporting and helping the patient report it.
Representative McLean.
Thank you, Mr. Chair. And this kind of, I understand Representative Merchant's administrative concerns with the amendment, and I share those concerns. But I do think that as we do these things, there has to be some teeth somewhere. I myself personally was very frustrated trying to opt out of the registry, and if indeed we do have a chronic amount of underreporting with respect to VAERS, I guess maybe you know the answer, just maybe you don't. Are you aware, are there any current consequences at all with respect to reporting, or what are they if they do exist?
The consequence would be with the Board of Pharmacy. If someone is doing something, the federal law requires it. And if you're not following the federal law or following the state law, the Board of Pharmacy has under its jurisdiction can at that point in time discipline the pharmacist for doing something they should have done. So the appropriate place to bring this is before the Board of Pharmacy, like any other professional board, because they're doing something that the law, federal or state, requires them to accomplish.
Two quick follow-up.
Follow-up.
Yeah, and I'm just trying to learn. Are you aware, or anybody from in this committee, of with respect to the registry or with respect to VAERS, of any activity in this regard, any hearings before the pharmacy board or the medical board? Is this actively happening, or is it just a checkbox?
I haven't been on the board now for about 3 years, but I can share with you my 10 years on the board. This would come under what they call non-public hearing. So therefore, the board would listen to the testimony during a non-public hearing. At that point in time, if it gets to a point of discipline, then the discipline will go into a public hearing. But many times, a lot of the things that are discussed because we're trying to protect the professional until some ruling occurs. So a lot of times we hear things in the board in a non-public manner in order to protect both the patient as well as the practitioner until the board ultimately makes a decision. So many times we've had things coming to the board and we act on it in non-public, but we came out of public and act on it in public as far as the actual discipline. No, I don't know because I haven't been on the board for 3 years since that point in time, but I could do some research. I don't know of anything that's been a problem. I do know at this point in time, there's been some concern by the medical community about not getting reports over to the primary care doc, but that goes back to the same thing. Sometimes the patients don't want to report it because the statute says only report it if the patient wants you to.
Representative Palmer.
So sort of in the line of this, because I'm definitely concerned about somebody losing their, for one error, losing their authorization to administer vaccines. And particularly depending on the severity, there's nothing here about severity. So I pretty much always have a low-grade fever after I get a flu shot, but that doesn't get reported. I guess I would be much more comfortable if this said something like 60 days of becoming aware of an adverse event in a patient result that the Board of Pharmacy would be notified, so that you put it back to the Board of Pharmacy, who has the authority to meet whatever justice is required by the offense.
Representative Weber.
Mine is also a question to the licensed professionals in the room who might be subject to this. It seems to me that we're all agreed that the difference with the pharmacist from a primary care provider or other who might have administered an injection, and of course, if we put this in here, it will apply to all injections, not just the new one. Is going back to what you were saying about if you get an injection from your primary care provider and suddenly your arm's turning red and looking icky, you go back and say, hey, I think that vaccine was a problem. What do I do about this? But you're going to do that with your primary care provider. You're not going to go back to the pharmacist and say that. And I guess one of the things I'm worried about is we have the becoming aware of language. And so you're at your kid's little league game and somebody you saw a week ago comes up to you and says, hey, you gave me that jab last week and, my arm doesn't look so good. And you say, well, I think you should check that out with your primary care provider. That was the first thing I'd do. But then your kid gets hit with a fastball and you're dealing with taking the kid off. This is tenuous, I understand, but there are reasons that it might slip your mind under those conditions that you were actually told about an adverse reaction and your license is now on the line. And I think it also goes back to the fundamental fairness issue, but if this is already required by federal statute, then it seems to me that adding it piecemeal into our statutes doesn't make sense. If what you want is for this to happen, it ought to be a standalone bill that then tracks the federal statute in our law. But if it's already in the federal statute, it doesn't need to be in our law. So that's my thought.
Good.
Representative Merchant, then Representative Cushman.
Representative Weber raised a good point. When you talk about revocation as permanent, in pharmacy today, if you cannot immunize a patient, you don't have a job. So you're not talking about this point in time of just losing the possibility of a license, but losing a possibility of a livelihood. So it's something not to take lightly. I don't think we should be ignoring the reporting requirements, but when you talk about something that's revoked with no termination to it, the consequence to the professional is dire. We're talking about that point in time is not just losing the ability to immunize, but if you can't immunize, you probably won't be employed by a pharmacy, Walgreens, and so forth, because they require you to have that certification in order to be employed there. So I just want to stress to you folks, the gravity of this situation is extremely high. And at the same time, when you're looking at the likelihood of it happening or people losing track of it to Weber's point of view, it can happen. And that one simple thing means all of a sudden your ability to provide for your family and so forth is totally off the table. And I think that's one of my concerns when you talk about this whole thing. The gravity of it's huge.
Representative Cushman.
Thank you, Mr. Chairman. I understand the concern there, but it's not true that if you can't administer vaccinations that you wouldn't have a job as a pharmacy tech. I mean, there are other pharmacies that are not public facing that do not administer vaccines. They deliver to nursing homes. They deliver to assisted livings. There are mail order pharmacies. There are IV pharmacies. There are pharmacies in hospitals and other medical facilities. I mean, is a wide range of pharmacy positions, and they don't all administer vaccinations. And as far as the scenario that Representative Weber posited, first of all, it's highly unlikely, but it's within 60 days. I mean, you have 60 days after hearing about it. That's 2 months to file the report, and I think it's a long enough period of time to give for someone to do that, and I really don't think that there's any excuse not to do it as a medical professional anyway. You know, and this is a privilege that we have awarded the pharmacists to administer these medical interventions, and we need to ensure that they are doing it safely. And if there's no reason that they wouldn't would not file a VAERS report, then this is just a heavy warning. If this isn't happening and they're doing their due diligence and following through with the care, then there's no consequence to fear. But I think that if they're not, that they shouldn't be administering vaccines.
I would also remind people that you're absolutely right, Representative Cushman, the technicians can give vaccines, but the reporting requirement falls on the pharmacist, not the pharmacy technician. So if a pharmacy technician was to give a vaccine under the supervision of a pharmacist, and the pharmacist is busy, they justify that the patient qualifies for the vaccine. They have a technician who's been trained to give the vaccine. Technician gives the vaccine and doesn't tell the pharmacist about an adverse event. It's not the technician who's going to be held accountable. It's the pharmacist, because they're the ones that have the requirement to report it.
Representative Representative Leon, and then Representative Alberga.
Thank you, Mr. Chairman. I think this is touching on one of the critical things that our current regulatory structure relies on. Post-market surveillance is critical in order to ensure the ongoing safety of any product that's approved by the FDA. I haven't dug into the specifications of the trials around the RSV vaccine, but I do know that the COVID vaccine was significantly handicapped by the fact that the crossover basically made it so that you couldn't evaluate any long-term effects. So that left that one vaccine to evaluate based on post-market surveillance through VAERS and other associated ways to catch adverse events in the community. I'm biased to what's happened in my career. We had the cardiovascular stents, the drug-eluting stents. They were great until they started flaking off and they started killing people with blood clots because they were only anticoagulating for a certain amount of time. Because people were keeping track of these events and because there were some pathologists who were really digging into it, they were able to determine what happened. But that doesn't always happen. Vaccines then have nebulous adverse events, and you end up looking at a very large sample. And with that large sample, you need to catch events in that. I would actually argue that those low-grade fevers are exactly the sort of thing that should be in there. Because you're looking at the whole universe of those adverse events. And then you would know that those are events where all you had was the low grade fever and you didn't develop other complications from that vaccination. Without data, we can't make decisions. And I think that it is absolutely critical that not just with pharmacists, but if we follow up in the future to have everybody else who's enabled to provide immunizations also have to report to VAERS. I think that that is absolutely critical in order to have a good quality of data, because right now those data are limited by the fact that only some events are reported. We're better off with a larger pool of data than we are with one that is one that's truncated. So while I appreciate that maybe there could be something about becoming aware in their professional capacity of an adverse event so that you're not hearing it on the ball field or in passing, I think that it's absolutely important that we have our pharmacists and our pharmacy techs as a first line of defense to catch any late events and to catch these ones that are not otherwise captured.
Representative Alberger.
Thank you, Mr. Chairman. My guess, based on basically no information except my own experience, is that the greatest loss of information about adverse reactions comes from the fact that we as patients don't report them. I've had minor aches and pains from COVID reaction, worse from flu, and even worse from shingles, and I never reported them to anybody. My guess is that that's true more often than not, unless somebody is extraordinarily ill. So trying to, in some way, hold a provider responsible for not getting information in leads the provider at a distinctly unfair situation. And the other comment that I wanted to offer is, if the reporting requirements already exist with federal law that have punishments attached, then setting another piece of legislation up here in New Hampshire is the Department of Redundancy Department. We had a conversation a little while ago about there are too many committees, and this in a different way seems to me very similar. Thank you.
Representative Palmer, and then Representative King, and then Representative Cushman.
So just to clarify, my position is I have no issue at all with getting data and reporting, and I agree with you that in the past we have not done well with post-marketing issues that have come up. I think that here the last sentence is that the punishment does not fit the crime. It's too severe, and if the remedy already exists in federal law, then great. If the federal law isn't strong enough, something a little bit less than, you're out. One strike and you're out. We need something a little bit less. So I'd like to see maybe a little compromise.
Representative King, and then Representative Cushman.
I see both sides of this debate. I agree with both sides. My question is mainly directed towards Representatives Cushman and Merchant. A possible agreement could be made if we just change one word. I'm thinking instead of shall, that could be may. So for example, instead of shall, it's like one strike, you're out, you're gone. And maybe it was just something as small as I got a bump on my arm and I didn't report it. The pharmacist didn't report it, and now all of a sudden they've lost. That seems pretty brutal. I get that. On the other hand, not having any teeth also seems like a recipe for unreporting. Whereas if we change shall to may, that would sort of put the ball in the court of whoever's making the decision. And it'd be like, hey, look, if this was such an egregious, event that it should have been, really should have been reported to VAERS and wasn't, then I could see there being a revocation there. But if it's something small, I don't know, just a thought.
Representative Cushman.
So I can clear up, there's a little confusion on what needs to be reported and what doesn't. So under VAERS, there are adverse effects that are considered that you should report, but they're not legally required to be reported, such as a low-grade fever, any new health condition temporally associated with vaccination. But what I've put here is I limited it to what's legally required under the federal law, which does not have any penalty at all. There is no enforcement of this anywhere. And so I limited it to what is legally required, and they are very specific. There are tables on the HHS website, on the VAERS website, of reportable events. These are things like Guillain-Barré syndrome, intussusception after a rotavirus vaccine, and Guillain-Barré is a paralyzing condition. Cardiomyopathy or myocarditis, thank you, after a COVID vaccine, that's listed in the table for reportable events for that. So these are very specific, and they're usually pretty severe. So it's not every little issue is going to be reported to VAERS. These are things that there really is no excuse for not reporting. To your question about the shall versus may, if I had my colleagues' support on that, I'd be okay with bringing an amendment to say may instead next week. But if not, then I would like to push forward with this because I think something just needs to be in the statute, and we have no penalty. I don't think that it's a crazy penalty. It's you either administer them and take all the responsibility with that authorization to administer them, or you don't administer them with the 60 days. And I mean, even having the revocation happen would require that the patient goes to the board and files a complaint, and it has to be one of these more egregious adverse reactions. And you went 60 days without doing it. I think that's a pretty high bar to or it's a low bar to set for for anyone administering something like this. So I hope that clears some things up.
Representative Weber.
Having listened to the debate here, as always in this committee, I've learned a great deal, and much of which I agree with, and then we all come to different conclusions, but that's okay. I would like to just put forward a process argument or a procedural argument and a conceptual argument, which is rather than add this into one place with one profession and without feedback from the general public, wouldn't it be a better way to proceed if what we're concerned about is the federal statute doesn't go far enough and doesn't have the sort of teeth that we might want to see? Wouldn't it be better to put in a new clean bill requiring this either with the shalls or with the mays for all professions, and let that get a vote up or down so that what we're doing is alerting everybody who administers these things in New Hampshire, reminding them of their obligations, rather than putting it on one small section and then having that robust debate about the shalls and mays, because I would be more comfortable with may if we're talking about the shall on line 12 as opposed to the shall on line 11. But if you just make it say may, then you've taken all the teeth back out again. And if teeth is what you want, then you need shall rather than may. So my suggestion would be that we pass, that we vote on, well, we can vote on the amendment, obviously, but my preference would be just to vote on SB 35 up or down and then decide, have a clean bill about the VAERS reporting that is consistent, has been checked clearly against the federal statute so that we can all satisfy ourselves about that, and then sets up policy that's the policy we want for New Hampshire and have it be set for everybody.
So you're basically recommending withdraw the amendment and vote ITL on the bill? Is that what you're talking?
No, I'm recommending, I'm going to vote no on the amendment, and I'm not going to vote for an ITL. I'm going to vote for not to pass.
Oh, okay,
But that's a whole nother question that we haven't gotten to yet.
okay. Representative Shapiro.
This is something I don't know about, but I feel like I've heard contradictory points of view about whether there's any consequences for not making a report.
Yeah.
I've heard that there's no teeth, the federal law does not have any specific consequences, but I've heard also that the licensing boards require that people follow federal law, and so that would be the place. Now, whether it happens or not is a whole different question, but that would be the logical place and the actual place where someone could take a complaint saying, I had an adverse reaction, it was never reported, and the licensing board would have jurisdiction to take some action on that with a physician or a pharmacy tech or a pharmacist or whoever.
That's correct. Basically, any licensing board, I mean, all professionals are required to follow federal and state law that's under their jurisdiction. If you're not following the federal or state law and it's reported to the appropriate licensing board, whatever that board is, then it's up to the board at that point in time to take appropriate action against the individual.
Representative McLean.
Thank you. So Representative Merchant, so even if the federal law does not have teeth in it, the fact that somebody would be going before the board for not complying with the federal law, they could still lose their licensure related to that.
Yes, and it's not just true with vaccines, it's true a lot of federal laws. If you look at things to do with controlled substance, for instance, and if you're, as a pharmacist, dispensing something that you shouldn't have dispensed, there's nothing in the federal law that's going to come after you. It's going to come down to the State Board of Pharmacy because they're the ones that control your license. So anytime, at least in pharmacy I can speak to, haven't been on the board, if there is a licensed individual out there who is not following the appropriate federal and state law, then the Board of Pharmacy under its jurisdiction has the ability to discipline the individual up to the point of taking the license away.
Follow up.
Thank you, Mr. Chair. So I think, having listened to some really awesome discussion, I'm kind of at a place where just looking at the administrative consequences of the amendment, I probably wouldn't want to support this particular amendment, but I think that Representative Cushman is bringing up, some very valid concerns. I think at the heart of it is in the fact that theirs is not being complied with, and there has to be some teeth somewhere. And more so, I think, as we become more fragmented. I know when I was a kid, my doctor gave me every vaccine, and as it becomes more and more fragmented, there has to be, we have to find a way to get some structure, because maybe it's because people aren't notifying on their own, or maybe it's just because the person who's administrating never has that opportunity to follow up. So I think, we need to look at that, but maybe not this amendment at this time.
Yep.
Representative Polazov.
Thank you, Mr. Chair. I still think this amendment is a good thing as written. The underlying bill has some very concerning effects with bringing authorization for in certain context for this new vaccine, and we received online testimony regarding severe reactions to RSV vaccine that can include paralyzing effects, and if somebody repeatedly, to be caught, it's probably repeated events that somebody is not reporting those severe effects, for example, for some batch of this of that vaccine. So permanent suspension just for one person who doesn't report it, I don't think it's too much, because as was said, like some other jobs that pharmacy tech could be doing. it's unfair situation for provider, but we need to think about clients as well. And like there was some scenario about like small bump, but for example, if we took at virus database 2038-120 report, a client had severe nausea and vomiting from 5 minutes post injections and for the next 8 to 10 hours. So if something happens in 5 minutes, there's a good chance that pharmacist would have seen it, but instead it was not reported. So time came and that patient was administered second dose, which caused severe nausea and vomiting for 5 minutes post vaccination, 103-degree fever, severe stomach ache, no bowel movements since the day before vaccination for 3 days in total, and ultimately that client died. So I would say if the first reaction would be reported, that client would be saved and maybe other clients would be saved. So yeah, yes, it's harsh for providers, but I think we need it for clients. Thank you.
Representative King, you had your hand up. Are you all set? Or?
Oh, no, I'm fine.
Okay. Any other debate? Any other discussion? Representative Weber.
I just wanted to clarify, I don't think you don't research VAERS to see if a specific person has had a reaction. So that's not the purpose of VAERS. It's to collect a broad spectrum of public health information so that we know that whole range of possible effects so that, but it's not intended to be a protection for an individual. I just wanted to make sure that we were clear on that.
Representative Merchant.
I would say to this committee, it's a lot of good discussion going on and touching upon some really important things. If we're really concerned to Representative Palazzo's concern about the patient and getting down to that level, one of the things for us to consider is that not only do we put the information into the VAERS program, but put it into the vaccine registration, because that's where most people are going to go look for it. So to your point is, I would say that information should go into the vaccine registry so that when the pharmacist is giving the subsequent one, that information is in that vaccine registry, which is what I need. And the VAERS doesn't help me. So I'd go back and say the same thing, is that we probably should be thinking about this in a broader sense in having the information for VAERS go into the vaccine registry and all professionals report it in that arena. So therefore we all have access to it to protect the patient, because ultimately at the end of the day, that's what we're trying to do. But if we don't have access to the information, we can't do that. So I would go back and saying, let's talk about a bill subsequent to this that all professionals who give vaccines have the requirement to put it in the vaccine registry so that everyone can benefit from it as well as the patient ultimately.
Other discussion? Representative Cushman.
It is part of what goes into the vaccine registry to report adverse vaccination events. Not necessarily that you filed a VAERS report, but there is a place for that too already.
Does it say what is the event? No.
I don't know what it
It just says you had an event, doesn't tell what the event was, if it was mild fever and so forth. But I think that's where we should focus our attention on, is getting as much information into the registry as possible so that we can be as conclusive to help the professionals out who are helping the patient ultimately to prevent dire situations to the patient. Representative Cushman.
Representative Nagel, do you have your hand up? Okay, I wasn't sure if you were playing it with your pen or your glasses or, okay, go ahead, I'm sorry.
Everybody's done a lot of really smart things, but oh yeah. Sorry, you really want to hear what I'm saying, don't you? So I think it's an incredibly important discussion, and it's so important that I don't feel comfortable to make a decision on this right now. I think that that we need to vote on it, yeah, but I really think that this warrants a bunch of people coming together, talking about it, working out the pros and
Ad hoc
cons.
committee.
An ad hoc committee, another committee of two. I mean, I'm actually proposing that. I think it's a great idea, and I think that this is incredibly important discussion with far-reaching consequences, and I just find it entertaining that this started out with a relatively very simple, I hate to use the word simple or common sense, because those don't mean anything to me, but, Bill, but I think you started a great discussion that really needs to keep going, and, there are parts of this amendment that I really don't like, specifically the penalty part. I think that needs a lot of work. I agree that there needs to be consequences, but I think they went too far. But your idea is awesome. It's amazing, and it warrants a committee of at least 27 people.
Representative Netter-Upham.
I usually don't have trouble making a decision on something. I read it and go, oh. And this one frightens me. I mean, I agree with everything you said about how important it is that adverse reactions be reported where they can be accessed. And I admire you for bringing this forward. I'm thinking about like leaving the room so I don't have to vote on this. But I would like an ad hoc or further study, and I'd like to just pass the bill. But I'd be, willing to, again, work on an ad hoc committee to bring up reporting. During last year, the year before, I got to watch 400 people receive vaccines in a facility that I worked at, a non-medical, and one had an adverse reaction, which, we had a 15-minute waiting area, and then somebody nudged me and said, that fella over there looks like he's passed out, he's incoherent, and he's sweating. And so we got the nurse staff to go. So, they do happen. So I don't know, but I mean, I passed it off to the medical professionals, right? Because I can't have him draw his symptoms away. Not those symptoms. I'm an art therapist. Anyway, so I'd like to vote down your amendment, but hope that we do indeed go forward with some kind of a committee, and that it applies to all professions that are giving out. And especially as we're hearing that other bill in the future about another group of medical people that want to give out vaccines. We need accountability. Sorry I went on a bit long, but.
Representative Shapiro.
I just want to say that I think if there are further discussions, they should really be dual discussions about where information about the adverse reaction can go that could be seen by future clinicians or who's ever giving future shots, but also that somehow reporting to VAERS is encouraged because, like I said, my experience was that it was kind of ho-hum, like I didn't get the impression, at least from my very limited experience, that everyone was making those reports.
Other discussion. Representative McLean.
Thank you, Mr. Chair. I just want to say, looking at the significant list of co-sponsors on this thing, I have enormous respect for that, and also for the intention behind this thing. But I do think that the amendment does need more input before it can go ahead. And so, like I said, in spite of all the respect I have for the co-sponsors, I just can't support it at this time.
Representative Alberga.
Thank you, Mr. Chair. And given that I'm not a member of the committee, I do hope that if some group is formed to discuss this, that it be very clear that if someone like me as a patient chooses not to report any kind of adverse reaction, that nobody, whether a pharmacist or a nurse or a doctor, gets held responsible for my decision to not report.
Representative Nagel.
I just wanted to make one more point that may be a little bit more general than specific, but it's germane to this. So A couple of years ago, I was involved in the development of a thing called the National Pain Strategy. So we met in Washington to develop this thing, and there were 200 people in the room sitting around talking about this, and they started bringing up points that were totally inappropriate for clinical practice. And so I finally raised my hand and I asked, how many of you guys are actually clinical doctors? Not one person in the room except me was a clinical doctor, and then I proceeded to tell them why this won't work. One of my big concerns about this that I think needs to be worked on is I'm not convinced it's enforceable. So, like, you know, you say you told blah, 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 I had it. Well, there's no record of that. So how do you enforce it? And then my other big concern from having dealt with the medical board, sometimes the medical board makes good decisions and sometimes they don't. And a lot of it's the characters that are on the medical board, or I'm sure the board of pharmacy when Gary was there was always, Representative Merchant was always perfect. But the enforceability was a concern to me also. But it needs to get worked on, and it needs to have the voice of clinicians involved in developing it. Otherwise, it won't be enforceable.
Any other discussion? I think we've pretty well discussed it pretty thoroughly. All right. Since we're ready to vote, I'll ask the clerk to call the roll. The vote is on Amendment 1413H to Senate Bill 35.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
No.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Polozov,
Yes.
Representative Weber,
No.
Representative McKay, not here, I'm sorry. Representative Freitas,
No.
Representative Cannon,
No.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant,
No.
Representative Elberger,
No.
Representative Palmer,
No.
Representative Priest,
No.
and Representative McDonald.
I know how Representative Nutter Upham felt. I too wish I could leave the room. That's not an option for me. No.
That is 7-4 and 12 against. 1 no vote.
So it fails 7 to 12.
Fails.
Okay, do I have a motion on Senate Bill 35?
Motion ought to pass.
Second.
Motion's been made by Representative Merchant, seconded by Representative Weber. Any other discussion that hasn't already been held? Representative Polozov.
I will be voting against, as I said, there's some compelling testimony about paralyzing effects from these vaccines, and it's being new. It's not sufficiently investigated. We know that at least one of the producers has a long history of not properly reporting side effects on timely manner, so it's a big concern for me. And second, I don't know how many constituents contacted you saying that they want it, but I had contacts from people who want to administer it, but I haven't heard about any emergency when we need to hurry up and have this vaccine. So for these reasons, I think we need to move cautiously, and I will be voting against at this time.
Thank you. Any other discussion? Representative Weber.
Well, I just kind of wanted to address some of the concerns expressed by Representative Polozov, and I think that he makes very good points about this is new. We don't know a lot about it, but on the other hand, if we believe in personal choice, And as we saw with the COVID vaccines, there were people who were very skeptical of them, and rightly so. There were people who wanted them very much and wanted them right away. And just allowing it to be administered in this fashion is a convenience for people who want it, but it doesn't compel anybody who has any reservation whatsoever to avail themselves of it. So I see it as being something that's offered as a service to our constituents, and none of our constituents have to actually do it if they don't want to do it. So I will be voting in favor of the ought to pass, but I do understand the concerns about, how much do we know and do people want this or not? But those who don't want it have the option not to have it.
Other Representative Cofalt.
Yes, thank you, Mr. Chairman. So I will be voting in favor of the ought to pass motion. I see this as a question of, well, I'll call it deregulation, which is to say, if an adult has given consent that they want to receive the vaccine, we ought to have a least restrictive approach to allowing people to administer that vaccine in a way that is as safe as it would be if it were administered by anyone who is permitted to do so today. I will also point out that the statute already permits the administration of a wide range of vaccines. This one simply adds RSV to that list. So I will be voting in favor of this.
Other discussion? Representative Cushman.
Thank you. I'll be really quick. I echo everything that Representative Cofalt says. I will be voting in favor of this, and I just want to kind of condition that, or not condition it, but I'm doing it with the hope and the assurance from my colleagues that we will work on something together to resolve this VAERS issue going forward, so we can make sure that as we keep adding more of these products to the list, that we'll make sure that they're followed up on. Thank you.
Thank you. Other discussion? Representative Freitas.
Just that I would like to thank Representative Cushman for the education that I got from this.
Absolutely.
So thank you.
Most excitement we've had all day. Other discussion? I see none. Okay, I'll ask the clerk to call the roll.
This is ought to pass.
Ought to pass? Yes, I'm sorry. Motion is ought to pass on Senate Bill 35.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Cofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
No.
Representative Nagel. Yeah. Representative Pelosi,
No.
Representative Weber,
Yes.
Representative McKay is not here. Representative Freitas,
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham. Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Elberger,
Yes.
Representative Palmer,
Yes.
Representative Priest,
Yes.
and Representative McDonald.
Yes.
We're glad you're still in the room too. 17,
I figured everybody could see me. So.
17, 2, and 1 not voting.
Consent?
Okay, the motion of ought to pass is successful, 17-2.
Is it okay for consent,
Consent.
or would the dissenters prefer to have it on the regular calendar?
Do the dissenters object to it going on the consent calendar? I'm sorry? Representative Palazzo?
I'm
It's
fine
okay?
with consent.
Okay, yeah, so without objection, we'll put it on the consent calendar. Okay, well, it's been certainly a full day, and I respect the fact, I appreciate the fact you remembered that I had to be out by 2, so 12 minutes to spare.
And who is writing the majority report for that one?
It was Representative Merchant who
Yeah,
wrote-
I-
who
Okay.
moved on.
Thank you, I missed that.
Correct. I'll write them. It's consent.
It's consent,
Okay.
yes.
I'll write the report. And by the way, when does the report have to be in?
Well, sooner the better. So I mean, today's the deadline for the calendar, so
Oh,
Representative Weber, what would you think, by next Wednesday, or? There's no House
next
session.
next Wednesday? Okay.
Okay.
All right. Okay.
Right,
Okay. Okay.
okay.
All right. Thank you.
Okay, so that concludes our business for today. Just so everyone knows, I have put the rest of the bills on for next Wednesday. We have no hearings left. So next Wednesday, we will be considering all of the other Senate bills, to include this one Senate bill that will be very quick and easy, called Medicaid expansion. Probably take just a few minutes, but actually probably more than a few. But so we have 8 bills left. So anyway, thank you all, and I'll see you next Wednesday.